Good evening, Dr. Bakshi, who is my co-host for the meeting. And thank you very much for the SOGO for organizing this meeting. Okay, so I will moderate the first part of the talks, which are 4 talks, and then Dr. Bakshi will take over for the second one. I'm going to request Dr. Jagdish Kulkarni sir and Dr. Sudhir Rawal sir to be the chairpersons for the first part of the meeting. And at the end of the 4 talks, I would request closing remarks from both of you, sir, just so that there are some take-home messages as to what has been talked about in those 4 talks. So to start off, I'm going to request Dr. Ravi Mohan Mavuduru to open the batting. He's additional professor in urology department of PGH Chandigarh. Okay, over to you, Ravi.
Yeah, thank you, Sogo, and thank you, Dr. Sanjay and Ganesh, for this incredible topic. I mean, it was a very difficult topic to navigate through. So, what I decided is I'm going to take you through why, where, and what about genetic screening in RCC. So, this is a typical patient we had a couple of years back, where 13-year-old male detected during his annual screening with this bilateral renal masses. Just keep this in mind, and then as we end the talk, we will try to answer this. So why it is essential to do genetic screening? Yes, because it helps us to understand the disease biology better. It in fact, because of this genetic screening only, where we have we have the mTOR inhibitors, we have the TKIs, we have mNET inhibitors which are into use. So it has been enabled only because somebody did genetic analysis of these patients, and it also helps us to identify novel targets. But the RCCs, there are only 6% of these RCCs, 6 to 9%, in fact, less than 10% of RCCs would have a germline mutation. This is one of the figures from a cancer atlas genome, which clearly shows that the percentage of germline mutation in RCCs is very less. So there's no point in doing screening for everyone. So that has to be understood. And familial RCCs are typically autosomal dominant, but the problem is incomplete penetrance. So you will have a lot of patients who would have one manifestation of one type and other manifestation even inside the families. So that has to be understood. Now let us discuss some most common clinical, most common types of familial hereditary RCCs. The VHL is the most common and most extensively studied. So VHL typically is a tumor suppressor gene, and it follows the TKI pathway. So all the drugs on TKI have actually been developed because of this understanding of VHL gene. It presents with hemangioblastomas of almost entire neuroectodermal origin organs like the retina, the brain, the spinal cord, and a lot of cysts inside endolymphatic cysts and cerebellar cysts. In kidneys, it presents with bilateral solid renal masses or even cystic renal masses, also with pancreatic cysts, liver cysts. And in adrenals, it may present with adrenal pheochromocytoma and pancreatic neuroendocrine tumor. For residents, typically, if you have hemangioblastomas and renal cysts and tumors, it is type 1 VHL. And if you have adrenal pheochromocytomas and hemangioblastomas, it is type 2 VHL. Now, the second common or most well studied is Brit-Hogg-Dubé syndrome, which is because of the folliculin gene, which again regulates the mTOR pathway. The tumors here are chromophobe type of RCCs with folliculomas on the face, very characteristic. In fact, most of the patients may actually be recognized because of this, or these patients also have lung bullae or lung cysts. So patients might present with the pneumothorax and then detect the renal tumor. So that's a common finding. And since it's an mTOR pathway, so Brit-Hogg patients would respond well to mTOR inhibitors in a metastatic setting. Now let's go on to the next commonly HLRCCs, that is hereditary leiomyomatosis and RCCs. These typically have collecting duct RCCs or type 2 papillary RCCs, very aggressive type of tumors. And these patients would have cutaneous leiomyomas. In fact, a young female might actually present with a lot of uterine leiomyomas at 20 years of age, and you must start suspecting that maybe we are dealing with HLRCC and she should be screened for it. And the defect in gene is the fumarate hydratase, which is a curb cycle enzyme. Another curb cycle enzyme which is associated with another aggressive type of RCC is succinate dehydrogenase related RCC. Here, these tumors are aggressive. They are associated with cysts and pituitary adenomas and paragangliomas of head and neck region and pheochromocytomas. So, if you have constellation of these kind of tumors, one must investigate for them. All these patients, mind you, are young patients. You might have an hereditary papillary RCC with MET mutation, a slow growing type of tumor, Then there is Peyton hamartoma tumor syndrome. There is chromosomal translocation. There is hereditary BAP tumor syndrome. These are well studied genomic genes which are associated with RCCs, and all of them have one or the other features to identify the type of disease. And I will not discuss tuberous sclerosis because they're mostly associated with angiomyolipomas and very rarely with RCCs. But then, being an incomplete penetration, you might have a lot of familial hereditary syndrome with family history of RCC, but you may not have any specific syndromic features. So these constitute actually the major bulk of patients to be investigated. And if for residents' sake, this figure shows all the. So when to suspect? Now it is clear that a patient who has a very early onset tumor, second to third decade, or patient who has multiple tumors, patient who has bilateral tumors, patient who has a very strong family history that is more than 2 relatives, or in RCCs with personal history or a family history, patients with unusual skin lesions, family history of kidney cancer syndromes, or unusual histology. So if you have unusual histology, multiple tumors, bilateral tumors, young patient, you must suspect and subject them for genetic analysis. Now, it is not that genetic analysis has to be done for every patient, or it just you send a sample and it is done. It has to have a proper genetic counseling, because the family and the patient must understand what are the implications, with respect to their peers, what are the implications with respect to their kids, what are the implications of identifying a genetic defect. So it is very essential that they should go through a genetic counselor before they go on for the sampling. There are no clear-cut recommendations. For clear-cut syndromes, yes, single gene testings can be done. But majority of the times you have to do a gene panel of 15 to 20 genes, which are the most commonly identified genes. And the best would be to do. The problem with NGS is a lot of background noise in NGS. So you would have to have a expert bioinformatics guy to tell you which is the
some disruption of signal from Dr.
And in institutes like PGI, we have NGS facilities as a part of research projects. But there are various private agencies, especially in Bangalore, and that they have very benign core. So like tuberculosis, just observe, don't do anything. For VHL, VHD, HPRC, or chromosomes, the ones which are associated with clear cell RCC or type 1 papillary RCC, again, they are very slow growing. So go very slow. Don't be aggressive in doing partial nephrectomy the moment you see it. If you can, enucleation has to be done rather than a good dissection, and you ensure that you close it as well, because you might have to come back again at a later date beyond 5 years. So don't rush into just doing radical or big partial here. But aggressive tumors like HLRCC especially, one has to do early intervention and do a wide excision. In fact, instead of doing a partial, go family members. Once you've detected a gene, what about family members? Do they need to be screened, and what is the age group? It again depends on the type of gene defect they have. So for patients with VHL or TSC gene defects, the detection has to be started as early as less than 2 years, because they might have retinal hemangioblastomas or even cranial lesions. For HDH and a P10 type of genes at childhood, and for other genes, it can the investigation can start at adulthood, beyond 18 years. Remember that it depends on the type of gene, and instead of obviously for decreasing the risk of radiation in surveillance of these patients, rather than just doing CT scan, low risk tumors. So coming to the same question, why, where, and what. So why it is clear that it has to be, because it helps us to understand that this is better. It helps to treat the patients and the relatives better. Where in almost all the young patients with bilateral tumors, with family history, with unusual tumors, and known associations with cutaneous lesions, yes, it should be done. What should be done is a little tricky thing, although we don't have a clear-cut answer. But remember, it has to go through a genetic counselor and an expert bioinformatician to have a right answer to the genetic thing. Thank you.
Thank you very much. That was all.
Thank you.
Just probably because of the time, I would just ask one question. do you feel that the incidence of these mutations are any different in our cohort of patients compared to what is in the literature, which is mainly Caucasian? Because you are a busy enough center, how often do you see it?
So for us, the advantage is a big risk training institute. So you would have a patient with one or the other syndromic feature, and one of the resident would pick up, okay, sir, this fits into one of these genetic problems. So I think ours is not a right center to answer that. Although I would say out of 500, we would see about 10-15 patients. So the incidence almost would be there, not much, not more than what we have seen in Caucasians. But I think we detect it much earlier than the common people. So again, it's the message for youngsters is that if you see some syndromic type of disease, don't just do surgery yourself. Try to refer it to a center, because then it needs a lot more understanding about the disease.
Okay. Just Raghavan, are you keeping an eye on any audience questions? Do you have any?
We have 3 questions. 2 of them said the sound quality is not good.
Okay.
And the third one said how to set up a robot. That's the question that have come so.
That probably is it will take the next 2 hours to discuss that one. So I think we have to pass on that.
So
okay.
What I would say is that we need to buy a robot first before we set up a robotic system.
Thank you very much, Ravi. We'll move on to the next one. So now that we have identified we have done the genetic screening, there isn't any problem with that. But a patient is now booked for the theater. So just I want to know how complex it is, what are the factors that help me decide whether this is going to be an easy one or a difficult one. So I've given the talk to Manav Suryavanshi, who is in Medanta Hospital, Gurugram, who is going to talk about nephrometry scores. Why should I bother about doing them? Manav. You can start up, Manav.
Good evening, colleagues. Can you all see my screen?
We can.
Okay. So I'll be taking you through nephrometry scores, what should one know and which ones to apply. And we'll talk about renal, Padua, centrality index, 3D nephrometry, zonal nephrometry score, arterial base complexity, in addition to Mayo adhesive probability. So renal, as all the first alphabet suggests, takes into account the radius of the tumor, its exophyticity or endophyticity, nearness to the collecting system or sinus, along with the qualitative aspect, whether the tumor is anterior or posterior, and the location. All these are graded in terms of difficulty from 1 to 3 points, and hence you end up having a maximum of a score of 12 with a suffix of A or P. If it is replacing the entire kidney, it becomes X. And if it is in the hilar region, it is qualified with an H. So you can see some of the images, and the score characterizes the tumors using their size, depth, location, and nearness to the renal sinus and collecting system. If it's completely endophytic, it's a technically difficult tumor. We'll rate it as 3, and closest to the sinus and collecting systems would have a score of 3 again. The polar lines are defined as the areas on corneal screen wherein you have the hypointense signal, and you draw a line bisecting them, as you can see in the diagrams over here. Something lying more than 50% or completely inside these 2 polar lines has a difficulty of 3, and as it grows peripheral, it becomes 1. So the score may range from a minimum of 4 to a maximum of 12. And as one would expect, low complexity scores were less likely to have a post-op bleed or urinary fistula. However, as the endophytic score increases, it becomes a significant predictor of post-operative urinary leak. The N, or nearness to the collecting system, had lowest concordance amongst observers. However, overall, the renal nephrometry scoring system had a good intra-observer reliability. Now, if we move through Padua, Padua stands for preoperative aspects and dimensions used in anatomical scoring. This actually is same as renal, but adds a parameter of lateral or medial location of the tumor to the rim, and hence the score may vary from rather than 12 have a maximum of 14. And the scores between 12 to 14 were 5 times more likely to have a post-operative complication. Coming to another score, that is the C index or the centrality index. It's a little complex one, but not exactly if you have an application-based system where you can just feed in the coordinates. It actually, in principle, is the ratio of the distance between the center of the tumor and the kidney center to the tumor radius. It tells us about the tumor centrality. Any tumor with a centrality index of less than 1 has some portion of its tumor superimposed on the kidney center. Anything that is 1 equates to tumor with its edge lying on the center. And as the centrality index increases, the complexity decreases because the tumor goes far away from the center. So those tumors which had a score of less than 1.31, greater than 9 times more likely to require radical nephrectomy. Lesser the score, higher the chances of radical nephrectomy. This scoring has actually correlated best with trifecta outcomes, but is difficult to calculate and has highest intra-observer variability. In a multivariate analysis, C-index and tumor size were the only significant predictors of warm ischemia time, and this scoring independently correlated with neither estimated GFR and percentage decrease in short-term eGFR outcomes after laparoscopic partial nephrectomy. So we have some variations trying to simplify these scores to improve the intra-observer variability. There is a 3D nephrometry scoring system. It's based on 3D models and softwares which calculates the tumor volume and predict tumor volume, longitudinal distance from tumor to equatorial plane. And these measurements are directly made in these models, and it improves the accuracy compared to 2D scoring systems because all others are 2D scoring systems. Then again, another simplification of the system wherein the authors propose zonal nephrometry scoring system. Herein, everything is similar, but they have divided the kidney into zones. So zone 1 is lower pole below the collecting system. Zone 2 is lateral to but not touching the collecting system. And zone 3 is upper pole or touching the collecting system. It's a simpler tool. It is made up of nearness to collecting system, physical location of tumor in the kidney, radius, and the organization that I just explained. Then we have another arterial-based complexity system. There are 4 categories to this system. The category 1 is in the renal cortex and encompasses only the interlobular or arcuate arteries. The category 2 tumors originate from or extend up to the renal medulla and reach a virtual line that connects all the tip of the renal papilla, therefore requiring transection of interlobular arteries. Then we have 3S, wherein the tumor may extend up to the renal sinus, would involve a transection of segmental arteries, and 3H involving the renal hilar vessels. This is actually a pretty intuitive scoring, easy to use, and demonstrates good correlation with perioperative morbidity. However, all surgeons you have seen talk about toxic fats and adhesive fats in their conferences. So the Mayo people have come out with Mayo adhesive probability score. Takes into account 5 factors, predominantly male gender, increased BMI, increased posterior and lateral perinephric fat thickness, and perirenal fat stranding. The 2 most predictive factors that came out were posterior perinephric fat thickness and stranding. And hence they ended up creating a MAP score that may vary from 0 to 5 on an intensity. And it gives us the likelihood of adhesive perinephric fat intraoperatively. So concluding, these scoring systems do standardize and quantitate tumor complexity and influence tumor selection by predictive operative outcomes. It is difficult at this moment to state that one of these methods is superior to others based on currently available evidence. However, Renal and Padua are the most common ones to be used. They should be used in conjunction with MAP scoring for better standardization and quantitation. Thank you.
Thank you, Mana. That encompasses all the nephrometry score ones. It's what I always find is there is one that is easy to use and that one that is commonly used. What I mean to say is which is the one that is most studied, so that if I'm comparing my series to another series, I don't need to...
So Sanjay, I missed out. I think you're asking which is the most easiest one.
No, which is the one which is most studied.
The renal one is the most studied one.
Okay. So Padua one or renal one is the most, renal one is the commonest one that is used. Okay. Thank you very much. Raghavan, any questions from audience?
So Manav, if you are using it, which one or two you use very commonly?
So we have used renal and Padua commonly. In fact, I ended up deciphering more and more as I studied about this topic.
So I think we use renal and MAP many times because it does give an idea about what will happen in the due course of the case.
I think they're different, isn't it? The renal and Padua are the complexity of the mass, whereas this is about the difficulty of the operation. So they are not a replacement of each other. They go hand in hand. Raghavan, any questions from audience?
I know. I mean, there were no questions. I was also checking on
Okay. Thank you. So this gentleman who is elderly.
One question: with expanding indications for partial nephrectomy and better technologies with respect to robotics and integrated AI, will nephrometry score hold its importance for counseling patients?
Oh, surely, I believe they will hold their importance not only for counseling patients, but for your training protocols also if you have a teaching or a residency program.
I fully agree with that.
Thank you. So just to go on to something that is not yet that very available, but it is quite a standard practice in Western societies, which is ablative therapies for renal masses. So I'm going to request Dr. Abhishek from Rajiv Gandhi Institute to talk about this. Are you around? Okay.
Very good evening, sir.
Okay.
Am I audible?
Yes, you are.
So is my screen visible, sir?
Yes, you go ahead.
Okay. Very good evening, esteemed gentlemen. I'm thankful to the organizers. I spoke to Dr. Bakshi and Dr. Sanjay, and special thanks to Dr. Sudhir Raval, sir, who is the medical director of our hospital. And as Dr. Sanjay said, it's something that is well established in the Western countries. And you can imagine a radiologist in a group of uro-oncologists, how I might be feeling, but still I'll try to do justice to the topic. And I'm going to talk about how ablative therapy is coming up in early RCCs, especially the T1A lesions. And I believe in batting like Virender Sehwag and Sachin Tendulkar, and I'm going to bombard you with the guidelines upfront, talking about the NCCN guidelines of 2021. So they talk about ablative techniques. Definitely partial nephrectomy is the preferred modality. However, ablative techniques can be offered to patients who have T1A lesions. Going into further details, the NCCN talk about thermal ablation is an option for masses less than 3 centimeters. And they also recommend that biopsy to be done for all these lesions prior to the ablation. These are the guidelines from the Urological Association. The American Urological Association talk about ablation as an alternative approach for management of lesions less than 3 centimeters in size. And kindly pay attention to how the European Association of Urology guidelines have changed from 2014 to 2019. In 2014, they said that no recommendation could be made because of the availability of low quality data. However, in 2019, they have offered that active surveillance, radiofrequency ablation, and even cryoablation can be offered to patients who are elderly and have further comorbid conditions. And the strength of recommendation is strong. This is the guidelines from Society of Interventional Radiology, which is the biggest IR society across the globe. And they talk about similar status where tumors, even ablation is safe and effective treatment with fewer complications than nephrectomy and acceptable long-term oncological and survival outcomes. Ablation should be offered over active surveillance in such small tumors, and percutaneous biopsy is recommended before the procedure. They have further talked about T1B lesions and oligometastatic RCC, but I think I'll skip it because of the it's not relevant to the current topic. So why are we even having this discussion? Because we know that increased use of cross-sectional imaging has improved the life expectancies, and more RCCs are now being detected incidentally. And we know that the nephron-sparing partial nephrectomy is currently the standard of care for management of localized RCCs because it has similar oncologic outcomes as compared to radical nephrectomy. However, patients who are not candidates for surgery, the ablation techniques can be offered to these such patients. So where is the evidence? Well, there are no RCTs till date. The highest quality evidence comes from population-based registry studies. However, they are always marked with a selection bias where ablation is being offered to older patients with more comorbidities and surgery is being offered to younger and healthier patients. So you can imagine this football field. This is how the selection bias has been in all these studies. However, when these studies were matched using propensity score and were compensated for comorbidities, they found positive results for ablation. And talking about underutilization of ablation, so this paper talks about ablation being offered to only 12% of the patients out of 75,000 patients who underwent nephrectomy or ablation between 2004 and 2015. This one particular paper talks about ablation versus section for stage 1A renal cell carcinoma, and they have demonstrated superior perioperative outcomes with short mean hospital stay, low unplanned hospital readmission, and a lower 30-90-day mortality, and conclude that in selected patients, thermal ablation survival may be comparable to nephrectomy. So these are the techniques that I've already enumerated. However, each has own advantages and disadvantages, but none is superior to the other one. So this is one such small tumor. You would see a small RCC enhancing lesion in the left kidney. And this is how, this is a microwave antenna. This is how it would actually was inserted. And this is the post ablation scan at 1 month, where the complete tumor is showing non-enhancement, is completely burned. Cryoablation is considered better in terms of ablation because we can control the volumetric ablation. And they have certain papers that talk about even T1B tumors can be ablated. However, it is still not available in India yet. And I think talks are about it coming to TMH Bombay soon. Then we probably would know some Indian data. So this is how you would see an ice ball while the ablation is going on. You can see how the ice ball is evolving and increasing, and you can control the ablation. I've already talked about biopsy and various how guidelines say that biopsy should always be done prior to ablation. Coming on to long-term oncologic data. So this paper is actually talks about, it's from the urology department only, and talks about long-term oncologic outcomes. And they have a 6-year data. And this is a busy slide. I'll just highlight that the 5-year cancer-specific survival was almost comparable, 99, 96, 100% for partial nephrectomy, RF, and cryoablation. And for T1A patients, clinically relevant difference between partial nephrectomy and ablation are unlikely, and treatment choice should involve shared decision making. An editorial commentary to this particular paper talked about how efforts should focus on optimizing the treatment for each individual patient and balancing between oncologic and functional outcomes. This paper also talks about a certain set of patients who harbor a KDM5C mutation. These patients have been shown to do poor in terms of overall survival. So these are the patients who probably would not benefit from surgery. And this is probably the future of personalized medicine, how individual treatments can be offered to such patients. Talking about complications of ablation, this is the guidelines from CERSE, another European society. And if you would see that the majority of the complications range from between 1 to 3% only and are generally minor in nature. Talking about the follow-up guidelines, how to image such patients. These are the guidelines that talk about all such patients should be imaged either with a CT or a MRI, depending upon what is the current the creatinine status, the kidney function status of these patients. If contrast cannot be used for such patients, they should undergo MRI. And the follow-up schedule is within the first year should be at the first month, then 3rd month, 6th month, 12 months, and afterwards every year. Talking about COVID-19 pandemic, it has already increased the complexity of cancer care, and it is all the more necessary to appropriately and fairly allocate limited healthcare resources. So this is where ablation can come in handy to patients who are not surgical candidates, who are at high risk of surgery. So those are the patients who can be offered such things, such treatment modalities. Just to briefly overview, to concise basically, percutaneous ablation represents an alternate to surgery for treatment of small T1A RCCs. The technical and functional outcomes are excellent. The rate of complication is very low. Procedure is minimally invasive and may be performed under sedation and as daycare. We are performing under sedation only in our hospital. The patients may undergo treatment with percutaneous ablation are those with ASA scores 1, 2, 3. And now we have more than 5-year oncologic data that is available and is pretty accurate. So this is how I would conclude that it should be offered to patients who are non-surgical patients, and maybe even considered with some benefit in T1B patients, which are not surgical candidates. Whenever it's a team effort, together everyone achieves more. So it is not a competing modality to surgery, but definitely it can be offered to patients who are not surgical candidates who are at high risk of surgery. So definitely data shows that it is much, much better than active surveillance and can be used to improve the overall patient outcomes. Thank you.
Thank you very much, Dr. Abhishek. I'm just going to ask a couple of questions of my own, and there is one from the audience. Who should do it? Because almost all these techniques can be done percutaneous and laparoscopy. I'm not talking about competence. Which one do you think is better?
So, sir, there is enough data now that say that percutaneous, basically data-wise, improve overall outcomes-wise, both are similar, but definitely percutaneous one is less invasive. We talked about the nephrometry scores. So again, it all depends on patient selection. So I would say patients
overall efficacy-wise, they are similar.
They are similar, but definitely percutaneous ones are less invasive, sir.
The second one is, you have mentioned this, and then the main problem seems to be the access to this technology. But one technology that we already have is the stereotactic radiotherapy, which is an up and come. How do these compare to that?
Personally, sir, I haven't reviewed the data between stereotactic radiotherapy and ablation in terms of RCC. But so talking about patients, I'm talking about these are the patients who are sicker, who have comorbidities, and we know that recurrences are common in such patients also. So I think if you're subjecting a patient, like we have done ablation in a patient who has had a solitary kidney also. So these are the patients who I would not want to subject these patients to SABR, because I would want future preservation of kidney function much better in terms of if I need to repeat it again, ablation is something that can be repeatable and easily done again. But in terms of head-to-head comparison, I don't have the data as of now, sir, which one is better in terms of stereotactic radiotherapy versus ablation. But again, we don't have the long-term data with SABR as of now, sir.
Okay. So just a statement from Dr. Shravan Singh saying that cryoablation has been available in PGH Chandigarh for more than 2 years. Statement. The question from was, what is the main impediment to use of ablative therapy in our country, from Dr. Santosh Vaingarkar?
So I would still say, sir, availability and interventional radiology is something that has come up pretty recently in India. Only recently, MCI has given its approval for a super specialty recognition to interventional radiology. Dr. Parekh is here from Miami, and I've been lucky to actually learn from Dr. Raj Narayan, Raj Narayan also was at University of Miami previously, and he's one of the pioneers in ablation in terms of all across the body. I still think gradually as technology would come forward, because sir, we need to realize that we're moving towards minimally invasive way of doing things.
So
robotic surgery.
Sorry, can I just so access is the main problem currently. Okay. Thank you very much.
There is one more question. There are a couple more. Dr. Abhishek, what is the follow-up protocol you use, or you send the patients to uro-oncologists for follow-up?
So we always work together as a team, sir. Primarily at our hospital, it's the uro-oncology who's dealing the.
How you do it? Quick.
So yes, so I showed in my previous slide. So we do it in 1 month, 3 months, 6 months, and 12 months, and then annually, sir.
Okay, so what would you do? An MRI or a biopsy?
So again, sir, it is done either through a CT or MRI, depending on the kidney function test. And in case we feel that there's something, a nodular enhancing lesion, or we feel there's a high risk of recurrence in terms of lesion size, then only we subject the patient to biopsy. Otherwise, we don't, sir.
Okay, there is a question from is it okay ablation in a small renal cystic tumor?
Again, so that's not something is indicated, because as long as so you're talking about cystic tumor who's proven to be RCC.
Role of biopsy and ablation. Suppose if it's RCC, cystic tumor.
So again, so with cystic tumor, again the chances of complete ablation go down, because again there's a heat sink effect. So again, those are the patients who would still prefer, I would prefer rather, even the data wide, they should be undergone a partial nephrectomy.
So there is a question last from Dr. Mahendra. What anatomical criteria you consider? I mean, how you said you select, so how would you better select?
So again, I would use a renal nephrometry score, the nephrometry scores. So there was a question previously. So that helps even a radiologist in reporting that actually adds on to the information that a uro-oncologist is looking from a radiologist also. So lesions which are exophytic, polar in region, those are the ideal lesions where ablation can score over, which have good data, good results.
Thank you. Thank you very much. We'll move on to the
Dipen wants to make a comment.
What I was going to say is it's a great talk from all the participants. For the last talk, there's a very nice slide with the selection bias in the football field. And the same thing could be used against ablations, because, the all nice, easy, simple locations, small tumors, you can do the ablation. When it comes to central tumors, when it comes to some of these other challenges, then they don't work. So the way I look at this is the selection bias is actually in favor of the ablation rather than against ablation.
Point well taken, sir.
Yes. So I'm going to request.
But you're right. We need to individualize treatment. There's a role for everything. You're right.
Excellent. So I'm going to request Dr. Dipen Parekh sir to give a talk on partial nephrectomy, factors affecting perfection. Yes. Dipen Parekh sir is Chief Operating Officer at University of Miami Health System, Chairman of, there you go, Professor and Chairman, Department of Urology, Victor A. Politina Endowed Chair in Urology. Okay, over to you, sir.
Thank you so much, Sanjay. Thank you, Sudhir and Ganesh, for giving me an opportunity to participate. There are a lot of friends and colleagues and my teachers in the in the panel. So, Dr. Kulkarni, Dr. Tungamkar, both of them are my teachers from 30 years back. And a lot of great friends and colleagues are also there. Yuvraj is there, I see him. Mallikarjun is there. So just such a pleasure to participate here. So I'm going to talk on partial nephrectomy, and especially looking at the trifecta, pentafecta. And I promise you, I don't know about anything else. My talk will be the most simple talk from the entire panel today. So that's my agenda, to make it as simple as I can. So my take-home message is my first slide, and my take-home message is that things that are most important when we are doing partial nephrectomy or nephron-sparing surgery for kidney cancer, the most important things are not in our control as surgeons. And the things that are actually in our control are important, but they're not that important in the grand scheme of things. And my talk will show you why I say that. So why is this whole entire concept of trifecta and pentafecta and all completely flawed? This whole discussion itself, in my humble opinion, is kind of meaningless, and I'll tell you why. So you look at trifecta, you look at negative cancer margin. Sure, part of the negative cancer margin, what you do while you do nephron-sparing surgery, has to do with the type of quality of surgery that you perform. Got it. Minimal renal function decrease with a warm ischemia time of less than 25 minutes. Well, warm ischemia time is a separate topic, we'll cover that. But the minimal renal functional decrease, very little of this is under our control as surgeon. Most of this is the baseline GFR, or what the patient has when he starts with this disease, and the quality and the quantity of the renal parenchyma that is remaining after the disease. So we have some role, but not a huge role to play in that. Urological complications are directly proportional to the complexity of the case. Despite our best efforts and despite our best technique, certain patients will have complications. And then you add to this the pentafecta, where you get over 90% estimated GFR preservation. Well, again, a lot of this is not in our hands. A lot of this is what the patient is, and the patient presents to you. And the same thing applies to the no CKD upgrading at 1 year post-operative period. Very, very little is in our hands. Now, all the factors equal. You almost see when you talk about these concepts of trifecta, pentafecta, imagine that they are like, these are not your children. It's not that trifecta is like your 3 children and pentafecta is your 5 children, and each child, you treat them equally. That's absolutely not true at all. In my humble opinion, when I am doing cancer surgery, for me, 99% of everything that I do is oncology. It's cancer. The most important factor in all these trifecta, pentafecta is oncologic efficacy. So 99% of weight I would give to that, and the other 1% is all these things about ischemia time and complications and all those things that are mentioned in those factors. So you have to always keep in mind when you're doing kidney surgery or nephron-sparing surgery about why you're doing this surgery in the first place, and that's oncologic efficacy. So what are the goals for partial nephrectomy when I do a partial nephrectomy? My primary goal is to make sure that I provide cancer cure. And the secondary goals, after I achieve the primary goal, is the renal function, perioperative morbidity, cosmesis, and other factors. But the most important thing that you don't want to compromise is oncologic efficacy. Now, so if you look at the key concepts, you want to just break this down. When you're doing nephron-sparing surgery, break this down into 3 things. There are patient-related factors that you have no control on as a surgeon. You can't do much about it. You can do some things in terms of preparing the patient better, and we'll come to that. There are some tumor-related factors that has been very elegantly covered in the previous talks in terms of the size of the tumor, the location of the tumor, multiplicity of the tumor, bilaterality of the tumors. But again, you don't control that as surgeon. And then there are a few factors that you can control that are surgical factors. The patient-related factors, age, BMI, other comorbid conditions, how sick these patients are when they present to you at baseline, any history of previous renal surgeries, these are very important factors that have a direct bearing on how complex your surgery is going to be. So that's something that you ought to know beforehand. So if you can control someone's diabetes, hypertension, you can ask someone to lose surgery if there's time, lose weight, something like that. Those are good, important things, preparing the patient before surgery and optimizing the patient, important. Now, optimize the patient, coming to that, I think it's critical that you do simple things. Make sure the patient doesn't have proteinuria, make sure the patient doesn't have any other underlying conditions. And there have been a study, a very strong study in more than 40,000 patients that has shown that when you look at diabetic patients, for example, and when you look at the mortality rates in these diabetic patients, just a simple visit to a nephrologist decreases your chances of death by 3 to 4 times. So controlling the blood pressure, controlling your diet, appropriately tailoring all your medications, these are important preoperative evaluations that you could be doing to optimize the patient. Now let's go to the tumor-related factors. Manav presented a beautiful summary of all the classification systems. I particularly don't think about any of these classification systems when I'm doing my surgery. To me, it's the tumor size, the tumor location. And the one thing that none of these classification systems take into account is the fact that when you finish doing your partial nephrectomy, what is the remnant kidney going to look like? If the remnant kidney is going to be in a way where the risks of complications are more than the benefits of saving that kidney, then it makes sense to do a radical nephrectomy. So I particularly in my practice, I don't look at any of these classifications, but Manav is right that they predominantly are helpful when you are reporting your studies, when you are comparing one series to the other. This provides you an objective metric. But in my practice, when I go to do nephron-sparing surgeries, and I've done more than 1,000 robotic partial nephrectomies, I don't think about these systems in my head and classify them as such. Now, what are the factors in literature that have been suggested to be important to make a difference? Again, these are all retrospective studies, and when you look at these, it's very clear. It's a location or the complexity and the size of the renal mass that determines how you do. And so how is that in your control? That's the whole point. It's not in your control. And then again, there's another study here, for example, that shows a similar thing, but in addition to all of these are retrospective surgeries, but in addition to the tumor size and the complexity, the surgeon's experience was also very important, which one makes sense because I think you can't replicate that. And it definitely counts in terms of the type of surgery you do, in terms of your efficiency in the operating room, your judgment. I mean, those are very, very important things. So let's come to surgical factors. Experience is critical. I think an experienced surgeon can provide a lot of value or add a lot of value when you're doing nephron-sparing surgery. And the key things that we'll cover is renal ischemia, the excision techniques, and the renoprotective drugs. So coming to renal ischemia, if for those of you who have not read, I think this is an article that I would recommend, notwithstanding that it was written by me, but I still feel that it does illuminate some key facts in our thinking about renal ischemia, or what should our thinking be in this day and age compared to what it was about 5 decades back, or over a period of 5 decades. One thing is very sure or certain, that this is not an ischemia talk. I have a separate talk on renal ischemia, so I don't want to belabor the point, but it has been very well shown that rather than the ischemia time, it's the baseline quality of the renal parenchyma and the GFR and the remaining quantity of the renal parenchyma after surgery that is critical in determining your renal function after partial nephrectomy rather than ischemia time. This is a collaborative review in European Journal with a consensus of multiple authors on this subject. And if you look at most of the studies looking at ischemia and partial nephrectomy, look at the things on the right side. Please look at the right side of your slide. Look at the level of evidence. It's garbage. Level 3, level 4 evidence that has dictated our thinking about on this subject for the past 5 decades. Again, level 3, level 4 evidence, there are about 26 or 28 papers that were evaluated in this particular consensus. There's only one study, which was a high quality study, a level 2 study, and that was done by me and my group about 8 or 10 years back on this subject. And what it basically shows, it's a very elegant study where you take preoperative urine and blood, and these patients undergo partial nephrectomy. Then all these patients undergo partial nephrectomy. And then in the post-operative period, we also take the urine and blood and compare the biomarkers in the pre and the post-operative setting. What you also do is the most important and the most unique part of this study, in my mind, was the whole kidney biopsy. So these patients who were undergoing partial nephrectomy had a baseline kidney biopsy in an unaffected area of the kidney before we started the partial nephrectomy. That established your baseline. Then once the renal hilum was clamped and the tumor excision and reconstruction was going on, we took biopsies from the same area every 10 minutes. Just before the partial nephrectomy was completed and we were unclamping, we took the biopsies, and that marked the maximum duration of ischemia and how the kidney looked at the maximum duration of ischemia. And once the clamp was removed, we took biopsies again at 5 minutes to establish reperfusion and to see if the changes in the renal parenchyma were reversible or irreversible after unclamping. All the biopsies were subjected to light microscopy, electron microscopy, and immunofluorescence. And what we found is when we look at blood markers, biomarkers, urine biomarkers, functional biomarkers, structural biomarkers of electron microscopy and immunofluorescence, there was no correlation with the duration of ischemia and structural changes in the kidney when you clamp this kidney, but most of these changes are actually reversible. We then studied the same cohort for 1 year duration and again found that the ischemia time did not predict renal function in the long term. This is a single surgeon randomized clinical trial comparing patients who are clamped and off clamp with partial nephrectomy. And it's a very nice study where these patients, in addition to the blood biomarkers, they also had a MAC3 scan, a renal scan, to look at the impact of ischemia on renal function. And it was statistically powered to answer this question. Long story short, there was no difference in renal function between those patients whom you clamp and those whom you don't clamp. And the baseline GFR, or the quality of kidney function, and the tumor complexity was predictive of the ultimate outcome. This is the CLOCK trial. It's a multi-center prospective randomized trial. All these patients, all these surgeons who are experienced, did more than 100 partial nephrectomies laparoscopically or robotically that they had performed. They all had normal contralateral kidney. The renal score was 10 or less, randomized to clamp versus no clamp. And they looked at the renal function at baseline and compared it to 6 months. Well, the first red flag for this trial was that 40% for the non-clamp arm had to be converted to a clamp arm at surgery. So think about it. Take a moment and stop. These are surgeons who have more than 100 partial nephrectomies under their belts. These are all experienced, good surgeons. And even in these hands, when they tried to do a non-clamp partial nephrectomy, 40% of them, almost half of them, had to convert to a clamp. So that's an important point to note. Even though it was a randomized clinical trial, and for any randomized study, the baseline population should be similar. In this case, it was not. There was still a huge selection bias in this study, where actually the clamp arm had a larger size, had more worse renal score, and had significantly more cardiac disease. So you are already pre-selecting the worst patients to be selected on the clamp arm. And despite all that, I mean, obviously this study would not have been allowed to be performed in the United States. You would have shut it down. But despite all that, despite the heavy selection bias, there was no difference in renal function between the two groups at 6 months in the hands of experienced surgeons. And there was no difference in complication rates. So obviously, the point I'm trying to drive is there's absolutely zero need to do zero ischemia. There's no need to do all those mumbo jumbo. There's no need to do micro dissection to the nth level of the renal vasculature. Your chances of hurting this patient is much more than helping this patient, and it really doesn't make any difference. I would rather clamp the artery and do your surgery under a relatively bloodless field so that you accomplish good tumor excision and reconstruction in a bloodless field, achieving good oncologic efficacy rather than doing this in a bloody field. The excision techniques, you can do a simple enucleation, you can do excision with a minimal margin, and some people believe in doing a much wider margin, if you will. It has been basically shown that in terms of cancer control, enucleation is not inferior to something with a negative margin. I personally, in my practice, try to get a margin, but I don't go for a very large margin. I basically go for, even if it's one cell layer deep, that's good enough in terms of cancer control. Renoprotective agents, there are multiple papers written on this. The bottom line is that none of these renoprotective agents like mannitol, Lasix, all these radical oxygen scavengers and all those things has not shown any benefit. So my take-home message is the most important factor is oncologic outcome. I think the tumor characteristics and surgical factors, they do play an important role. Limited ischemia is safe to perform partial nephrectomy. Enucleation or with a small margin is good enough. There's no role of renoprotective agents. And I think the pre and post-operative preparation of the patient is important. And again, the take-home message, things that are most important for outcomes in this patient population are not in our control. And these are tumor biology, baseline renal function, tumor complexity, and the patient himself or herself. And things that are in our control are important, but are not that important, like ischemia time, the surgical techniques, and surgical approaches. Thank you very much, and I'm happy to take questions.
Thank you very much, sir. That was brilliant talk. I just had one question. Let's say that I know you don't believe in the trifactor, but comparing your open to robotic, which technique gives you better chance of achieving either trifactor or pentafactor?
So look, the robot, it all depends upon your training. If you are comfortable,
that's what I was asking you.
Yeah, if you don't have a robot in your setup, or if you're not trained to do laparoscopic partial nephrectomy, which is a very challenging procedure, and if you're an outstanding open surgeon, you can give the exact same outcomes to a patient as anyone else, with the only caveat that your patient will have an incision and your patient will go home maybe a day later than someone who goes home with the robotic approach. But if you don't have that, and if you're an open surgeon, and if you're doing a great job with this, there's nothing wrong with it. You'll have the exact same outcome as a great robotic surgeon.
Thank you very much. There is one question from Dr. Sharad. Post-op GFR not only depends on ischemia, but also renorrhaphy that takes away some definitive function in partial nephrectomy, however well executed. So you think that renorrhaphy, we should decrease the amount of bunching that we are doing?
Well, so these type of things, they're just nitpicking, basically. It's like, you telling me that if you're doing a PCNL for renal stones, and if you're doing 3 or 4 punctures, then that little tube that's going to destroy a few nephrons in the tract, they're going to affect renal function. That's literally nitpicking. I mean, to me, there are a lot of people who just leave it alone. They don't even close the kidney layer. All you're talking about is a few sutures to close your defect. So even if there is, let's assume there is a small impact, that impact is really minimal.
Thank you very much. So I'm going to request Sudhir Rawal sir and Kulkarni sir to summarize what we have learned. Thank you, sir.
Sanjay, can I ask a question if we have time? 1 minute to
Yeah.
Dr. Dipen?
Yeah.
Yeah, Dipen. Hi, Dr. Ravi from PGI Chandigarh. My query was, I agree with your point, perfectly agree. But then, how do you compare your data with across the borders? The only reason why you need some outcome analysis like trifecta or pentafecta is probably to compare across the board your outcomes versus others' outcome. What is your take on that?
Well, so like I said, basically, if you want to, but these are, first of all these factors or whatever you do it, these are all, man-made definitions or guidelines. There is no data to show that that's the best outcome. I mean, you can provide a best outcome to a patient, 75 years old, who dies in 6 months with a heart attack, where you did the best job that you possibly could, but the patient died because of other competing factors. I think these are all good things to compare your outcomes with others' outcomes, realizing that 80 to 90% of what you're comparing is not in your hand. We like to think as surgeons that we have this God complex, that we are the hands that are curing the patient, that we are the things that we are doing all these things, which is right. We do play a major role. Doing a competent surgery is not a joke every single day. So don't get me wrong, but it's just a part of the equation. A major part of the equation is the tumor biology, the patient himself or herself, and other factors that are not in our control.
Thank you.
Thank you very much. Kulkarni sir and Rahul sir, can you
Yeah,
summarize?
yeah, Sanjay, thanks, and thanks everyone who gave the talk in this session. And it was a great session to start, and especially that start was with the genetic changes and what is the mutations are coming in big way in RCC. And we actually had recent panel discussion type in Rajiv Gandhi, and there are many things coming in RCC, not only already existing because of the lot of immunotherapy and other things have come. Even the papillary 1 and type 2, their things are changing. In papillary 1 because of the FH mutation, there is some subgroup are slow growing and some are fast growing. And then we have translocation changes in patients who have IVC thrombus, and then we have PD-L1 changes. So this was nicely summarized by Dr. Ravi. Next was Manav, as usual. This was a great talk, and definitely we also do the renal and Padua. Everybody does the good center they do, and they are to compare the outcome. But I'll definitely I will agree with the pain here that when you operate, it is you and the tumor. In the beginning, when we did not have ultrasound, we were doing it without ultrasound, and we could do the surgery. Ultrasound now I feel is the helpful only in an absolutely endophytic tumor. Otherwise, Padua renal scoring, it should be done in all cases in a good center who are doing these surgery, and they can also come out with some new ideas. Like now the renal fat around the perinephric fat has also has played a role in this scoring. Now the third talk by Abhishek was, if you remember, I don't know how many of you have seen a paper long back, maybe 10 or 12 years back, or maybe earlier. There was a paper in Urology Gold Journal, and that was that surgery for SRM, small renal masses, go, went, and gone. This was the first page topic. This was written very enthusiastically, and at that time I quoted this paper in our meeting also when radiology meeting tumor board was there, and at that time a lot of data came for the ablative surgery, ablative therapy. I used ablative therapy in a patient who had recurrence, recurrence tumor, like he had single tumor with partial nephrectomy, and he again failed locally. So he had microwave evaluation. Sorry, we have ablation here, which Dr. Chaturvedi and Abhishek and they are doing. So I used in those settings, but then the data came that this probably has some compromised outcomes. So should be offered to the elderly and the patients who are comorbid and not for which Abhishek agrees also. And definitely, I think the things will evolve in this field, and having the cryo, and we have a microwave also, and in the future, probably something else will come. The things may change. Even HIFU is there, but it has not picked up. And the SBRT, which you mentioned, probably will be better with proton. If you do the proton therapy, then the data may be different. So the things will change in this setup, in this type of the treatment. But this was a great talk by Abhishek. And Dipen, I think he has shown the things from a different angle. Rather than talking about trifecta and pentafecta, he has gone to a more practical things, which actually matters. And I'm really happy to see that zero ischemia is not a necessary. And I myself has done clamping the artery for a single kidney with a big tumor. We have a video in urology, that uro-oncology technique channel on YouTube. And I do it routinely for left-sided IVC thrombus going to the left-sided kidney, and thrombus going to IVC, and then I have to clamp the right renal artery. I do it routinely. I have done even robotically also without compromising any outcome in the renal function. So with that, I'll say it's a great session. Sanjay and Ganesh, this was a great program all over, and I'll ask now Dr. Kulkarni to give his comment.
Good evening to all. Am I audible, please? Hello? Am I audible?
Yes, sir, you are.
Voices.
Hello? Okay. Now, I echo what Dr. Rawal has said. Everything is absolutely done very well. But to add to something which I have to say, that as far as genetics is concerned, we are still in new, and I do not know how long it will take for us to make it into clinical practice. Regarding nephrometry, well, I am now getting a feeling that we must use more than one system rather than two. Coming to the ablative therapy is going on for the last 30 years, and I'm sure there are center of excellences which are continuing to do that. And I think, at least for my lifetime, it still remains in an evolving system. Lastly, coming to partial nephrectomy, Deepan, I must thank you for giving us an enlightening talk on this. And I'm impressed with you. You have really started with a take-home message first and bring back the work towards that, which is, I think, a new way to do. That we must look for the messages first and then work on the backward. I can gather three messages from this: is look at the residual kidney, look at the baseline quality of the kidney, and lastly, the most important point is clamp versus non-clamp. The issue is already settled now. I think we must go for a clamping and make it more surgically accessible and make more simple procedure rather than making it complicated. Well, I'm extremely thankful to you for giving this enlightening talk. And with this, I say that, well, we have a great start. Thank you very much.
Thank you, sir. Before we end this session, Sanjay, there are two questions from the chat. I'll address one to Dr. Kulkarni. Sir,
Yes.
if warm ischemia time is extended, is there a role of intermittent clamping?
Well, this Deepan is nodding. Deepan is already nodding the head. The issue is settled. Don't worry about that.
So, Dr. Shailesh Raina, question. This is to Dr. Rawal. How often would you do a selective embolization for a large tumor or robotic partial?
I have never done it. I probably, if it is so big that I have to do selective partial, I will go for open partial.
Yeah, exactly.
Yeah. So we go ahead with the next session. I invite the chairperson, Dr. Mallikarjun, who is our president-elect of USI and a renowned urologist, and Dr. Anand Shivraman, who is a dear friend and a very known uro-oncologist from Chennai. I invite the speaker, who is again a very dear friend, Dr. Sanjay Adla, who will be talking on open NSS, but what robotic surgery has taught us. It's a very relevant topic for the time. And Sanjay, go ahead with it. Sanjay is a consulting uro-oncologist at Apollo Jubilee Hills, Hyderabad.
Okay. I'm expecting that it's visible.
Yes.
Okay, fine. So the key to this was the taught us. So rarely does anyone do robotic partial nephrectomy and go back to doing regular open partial nephrectomy. The way I wanted to look at is, let's say a trainee learns to do robotic partial nephrectomy and then goes back to a center where there might not be access to robot, then what are the take-home things that he can take from a robotic program? So what has the robotic surgery taught us? It has allowed centralization. The reason why I've used this way is that there is a lot more research currently available with respect to partial nephrectomy compared to what it used to be. When we were doing open partial nephrectomy, there were loads of more surgeons who were doing it, because of which there was no aggregation of data. Whereas robotic access to the technology was less, because of which it allowed centralization. And Deepan sir has very well illustrated, the more you do, the better you get at it. And this has allowed better understanding of the factors. The more you do it, you realize even the minor things matter, both with respect to the ease of the operation as well as the outcomes. So answering the question, what is the robotic impact on open technique? This is my own series that was published. So for me, I did about 100 open partial nephrectomies before going on to robotic partial nephrectomy. So I looked at it and saying whether there was any difference. But if you look at the learning curve as such, probably I had my learning curve with respect to partial nephrectomy when I was learning open partial nephrectomy. So that's why the robotic was much more easier. So this one was comparing 108 robotic partial nephrectomies to open partial nephrectomy. When you look at it, I know Deepan sir will say not relevant, but cold ischemia time were compared to warm ischemia time statistically significant, but numerically almost similar. But when we look at the overall complication, other significant complication, were all similar. There was no difference. But as I said, this wasn't actually my learning curve of robotic, because it was a robotic learning curve, but the partial nephrectomy learning curve probably happened with my open partial. The key difference was that the length of stay was much shorter with the robotic compared to the open, suggesting that you're almost getting the outcomes that you would get with the open, but much quicker recovery with respect to the patient. The second one, is there a learning curve? All the people who, especially in the Western societies, who start off on a robotic program would have done 100 or 200 open or laparoscopic partial, and then they go on to the robotic. But is that the case? Is there a learning curve? Again, this one published in BJUI, wherein we looked at in the north of England, looked at 250 robotic partial nephrectomies. All the surgeons, including me, had already done around 100 to 150 open or laparoscopic partial. But what you see is that when you look at your early to later, even then there is a learning curve. So I don't think there is any phase wherein you say, I have mastered it. It is always a learning curve. The more you do it, the better you get at it. The warm ischemia time, it tends to decrease. Mainly the positive margin rate, if you look at it, that does tend to decrease. The complication rate is around the same. Okay. And the complexity, when you look at actually the individual surgeons, the numbers are the same, but the complexity of what you take on does tend to increase as you improve your learning curve. So what has robotic surgery? Let's say if I start doing open partial nephrectomy from tomorrow, what are the things that I need to look at? What has robotic technique taught me? It has taught me all these sort of things. Okay. And I'm just trying to go through all these things in a detail. Let's look at the patient selection. What I was asking Deepan sir was, body habitus was a key component of open partial. The moment you saw a patient and thought, I need to do an open partial on this guy, you almost gave up if they were very big. Whereas when you do a robotic surgery, yes, the access is a bit difficult, but inside the operation is not that very restrictive. So yes, obesity and the body habitus does play a role in robotic as well, but it plays a much bigger role in open. But these are the non-modifying. This information has come in more when we started looking at the robotic partial, wherein all these factors are extremely important, and we need to be aware of what are the factors that we can't modify, which will have a significant implication with respect to the patient outcomes. Tumor selection, importance of CT reconstruction. Again, this is when you compare open to robotic, you do not have the tactile feedback. So there is a lot more emphasis on knowing where actually the tumor is. And especially for something that is covered with toxic fat, it is much more important knowing where the tumor is. So reconstructions is something that is here to stay. Nephrometry scores, we have had a discussion, so I will let it pass. MAP scoring is very important. I'm just going to show you here. What Manav has shown is quite important, but what you see here is once the MAP scoring increases, this is the probability of having toxic sticky fat. So if you're going to start off doing a robotic program, and the first case you choose is somebody who has got a MAP score and the fat doesn't come off, be wary of it. So other than the renal score, MAP score is also important just to predict whether it is going to be a difficult surgery or not. Operative technique wise, we used to do minimal. So the moment you saw the hilum, we used to do mass Satinsky clamping. Now we do a lot more dissection and we are going for selective clamping. What is correct? All of them are correct. Now we at least know that you can get away doing so much more dissection. Vascular clamp, as I said, we have gone on to the selective clamping. We used to do cold clamping. Now we know warm ischemia, and Deepan sir has said even under 30 minutes is a bit of a number that is picked out of thin air. You can go a bit higher as well. But we know kidney does tolerate warm ischemia time, which is something new compared to what we used to do in open. Usage of peroperative technology. Earlier, there are loads of options that are available when you do robotic, but at least in open, you can always use an ultrasound scan. Operative technique wise, we were doing heminephrectomy. Now we know that even if I'm doing an open, I don't need to take out the whole of the upper part of the kidney. I can go for enucleation. Rhinography, again, bolster is out of fashion. We know that we don't need to be closing the kidney down completely, opposing both the edges. As long as you have ensured there is collecting system is closed and major arteries are tied off, it is fine enough. and minimal usage of ureteric catheter. I used to put in for almost every patient. Nowadays, I rarely do that. Post-operative care, as the enhanced recovery has almost taken over this part of it. I used to have patients who would be on complete bed rest following a partial for 3 to 4 days, whereas now a robotic partial goes home the next day. Even an open partial goes home in around day 2 or 3. So this one regarding immediate mobilization, starting to feed immediately, those things have improved because our understanding of the operation has improved with robotic surgery. Perioperative management, calyceal opening, we are not that very pedantic about it. We can just include it in our inner layer. To drain or not to drain, I would leave it to the seniors whether they always put in a tube following a partial nephrectomy. I do, because I can sleep better. Positive margin, if it is a microscopic positive margin, we know from robotic partial series that because you are using diathermy, it doesn't have significant impact with respect to their survival. It does have a significant impact with respect to recurrence. So what is the summary? Volumes matter. Robotic surgery does tend to improve your volume. It has improved our understanding of the partial, and that's what has altered both the pre, peri, and post-operative care when it comes to open partial nephrectomy. Thank you very much.
Thank you, Sanjay. And there are no questions in the chat.
Depends
Ganesh,
on
may I have a comment? May I make a quick comment, Ganesh?
Yes, please.
Yes.
Yeah, so this is the second talk where I've seen this reference. So first of all, great talk. I really, really enjoyed your talk. Very concise, very practical. I've seen a couple of times now about this whole sticky fat thing. What are you going to do about it? Are you going to stop operating if there's sticky fat? If you know preoperatively on the CT scan, that, when you're operating on a male beyond a certain age, you know that you're going to find sticky fat. But how does that change anything? I mean, are you going to change your approach? Are you going to, you have to just bear it and go through it and do the surgery. It's going to bleed. You're going to be subcapsular at many levels, especially in males with sticky fat and stuff like that. It's just the nature of the beast, basically. It doesn't change anything what you do, but people like to talk about these things.
Just only point is that it doesn't change much when you have done 1,000 partial nephrectomies, whereas if I'm starting my first one, I would be wary of taking somebody who has got very sticky fat. It just would demoralize me. That's the only reason.
What's the difference between sticky and very sticky?
Something that doesn't come up.
There are no more questions actually in the chat, and I think we go on to the next presentation by Dr. Ginil. Dr. Ginil, could you play it, share, or you want us to do that? The topic is laparoscopic partial nephrectomy, how to decrease the complications. And Dr. Ginil, as we all know, he is a professor of uro-oncology at Amrita.
Can you see the slide, Ganesh?
Can, please.
Yeah, thank you. So Deepan has rightly told that 90% of the issues related to partial is not in our hand, but the 10% which is there is very important in partial nephrectomy because that decides usually the outcome. And partial nephrectomy is one surgery where we require a lot of skill and experience if you are doing it through laparoscopy. And most important factor I will say in the initial part of the life with the partial nephrectomy will be selecting the patients, because if you are wrongly selecting the patients in the initial career, you are doomed. So initially when you are selecting to reduce the complication, you should be very selective to select easy patients till you get the confidence and experience, like exophytic tumor less than 4 centimeter, polar tumor, anterior tumor. You avoid surgeries with laparoscopy on complicated vascular anatomy or solitary tumor or multiple tumor. This is the most important thing I will say in the initial part to reduce the complication. So second part is actually select the patients, because a complicated patient, or if a patient has got some medical illness like Deepan rightly told, these are the patient factor you should be careful about, because if you are having some problem, it will be very difficult. So avoid complicated patients, at least in the initial part. Select safe tumors. Then assess yourself whether you can you can finish the surgery without much problem. These things has to be there as the next step to avoid complications when you are selecting a patient. Most important factor I will say is the CT. Whatever be the renal score, we have to check the CT, assess everything about the tumor, everything about the kidney, its vascular anatomy, the vascular anatomy related to tumor complexity, and most important factor is, I will say, is the complexity of the tumor. And one factor which is often neglected is whether it's a T3, whether it has got a sinus involvement or it has got a bad fat around, because if there is a perinephric stranding, it can be difficult on table. So you can see that this kind of tumor, which is anterior, small, going, not dipping into the pelvic system, are straightforward for a partial. If it is a very complicated tumor, go for an open, or if you have got facility, go for robotic. Don't actually experiment initially with your laparoscopic scale. So these are posterior tumor with multiple vessel is actually not a patient who can undergo a laparoscopy at least in your career unless you are well experienced in it. Renal score, as rightly told by Tipan, is not for comparison in a study, but each and every patient tumor has to be studied before you venture onto laparoscopy, because in laparoscopy it is very important to because you may not have a escape route if you are getting into complications. So housekeeping, yes, a few of the things, whatever things you want, you have to keep in advance, because you will not be having time to search for all these things. Most important factor is the vascular clamps you get. These are the two types of vascular clamps. One is a bulldog and the laparoscopic clamp. A good scissors, because a scissor that is not working properly can affect the outcome in the laparoscopy. There are 2 layers of suturing, and usually we use the sliding technique for securing the hemostasis. So Stratafix is the usual suture I use. Earlier I started with 3O white clip, then I switched off to Velo. Now I use Stratafix because it is more pliable. And second layer, I usually use the white clip. Velo 2 is another option. But there are a lot of, in between surgeons, there are a lot of variation about how many layers has to be there, what type of sutures are there, is all individual preference. The laparoscopic clips are available outside, but it is not available in our country. So something about vascular clamps in laparoscopy. Laparoscopic vascular clamps is one factor which you should be good at applying. This is the bulldog clamp, Scanlin, and this is the usual laparoscopic clamp. A small thing about usually laparoscopic clamp are clamped, the vessels are clamped and blocked, but in the bulldog, it is separately, the artery or vein are separately clamped. So when you are applying the clamp, the direction of the clamp is very important. If it is from anterior aspect, it will be very difficult to manage the kidney and put the camera in. So it is always has to be from an angle. So the port has to be properly placed, and the camera should not hit the laparoscopic port while you are manipulating. So the port placement for laparoscopic clamp is very important if you are using the laparoscopic clamp. So, but in the bulldog, you can see that once you are putting the bulldog, the space is free. And again, another important factor is always put the clamp close to the great vessels, because then only you will be able to manage or manipulate the kidney if you are going for posterior aspect. Regarding simple enucleation or enuclear resection or standard partial nephrectomy, all these things are possible in laparoscopy, but we see that the accuracy of resection may not be as good as in open or robotic if you are a master in the laparoscopy. And the standardization of these terms are actually debated. when you are excising the tumor, the direction of scissor is very important because initially you scissor, the scissor tip has to be parallel to the tumor. Otherwise, you will be going either into the kidney, causing more bleeding, or you can go into the tumor, causing a margin positivity. So, how the hemostasis can be achieved? Usually, majority go for 2 layers. I will usually go for 2 layer, but if it is a superficial tumor, you can get along with 1 layer. But the 2 layer is better to either go for a continuous or go for an intermittent according to your experience. But always see that the major bleeding vessels are secured in the suture, because once you do the second layer, it will be very difficult to go back again, especially in laparoscopy. The second layer, where to put the needle is very important. If you are very close with the wounded, you may not get the capsule and tumor, the kidney parenchyma may tear. And if you are going well away from the incision, actually the ischemia can be high and your needle track may be deeper and can injure the vessel. So there's an optimum distance and optimum angle you have to follow when you are going for a second layer or sliding suture, the second layer, and the sliding suture technique is the usual thing that is done. So point to remember, so you should select the patient so that you can avoid a laparoscopic radical nephrectomy. If open or robotic partially is possible, avoid laparoscopy for a complicated tumor if you are not confident with. Oncological and functional outcome is very important and should not be compromised. Lap partial is safe for selected patients and its economic cosmetic advantage is there and is actually a good option, especially in our setup. So lap partial needs a lot of scaling. Patients are different, surgeons are different, outcome depends on you and your patient. Surgeon should select a good patient and patient should select a good surgeon, then both are safe. Thank you.
Thank you, Dr. Ginil. And just
Ginil, is this one of the things that Deepan Parekh said about not in the hands of us and hands of somebody else? Your last point? A good patient and a good surgeon.
So actually what I try to say is you should be confident about yourself and you should be selective. Then it is in your hand. Otherwise it is in somebody's hand.
I appreciate that.
Okay.
I just want to make one comment. When it comes to difficult cases, a difficult case is a difficult case, whether you've done 5,000 or 10,000 or you're starting off. And that's why before you embark on your journey, on your surgical career, if you know how a very experienced person navigates a difficult case or deals with it, it really helps a lot. That's why you do fellowships and stuff like that. When I did a fellowship at Sloan Kettering, when I did my training at Vanderbilt, to me, I always knew that, and that's where I learned that when it's a difficult case, a master surgeon or experienced surgeon will accept that, will keep moving, and give the best outcome that is possible in a difficult case. Whereas when you're a novice, you are more tentative in a difficult case and you make a difficult case even more difficult. And that leads to more and more, it's just kind of, you keep on digging a hole. So that's the difference. Being aggressive in surgery is okay. Being tentative in surgery is the worst thing.
Thank you, sir.
Quite good tips from Deepan. Doing laparoscopy for a NSS is a slightly more difficult procedure than a robotic. And Ginil, we appreciate that you made this very excellent presentation. So there was one question remaining from the chat for Sanjay, which was any particular location of tumor where robotic will score over open, or it is nothing like that?
I think it's more of if you are doing transperitoneal or retroperitoneal robot. So if you do a retroperitoneal approach, it is exactly as a line approach for an open partial. So all your posterior tumors are in front of you. Whereas if you do a transperitoneal, all the anterior tumors are in front of you. So if you have got technique of doing both of them, then robot will always score over an open.
Okay. So for the next session, next talk is by Dr. Deepan. He's already been introduced. He's the chairman of urology at Miller School of Medicine, University of Miami. He's a very talented urologist, uro-oncologist, and I have learned robotics from him. And we have particularly asked him to show a video tips about a robotic partial nephrectomy for a posterior renal tumor.
Thank you very much, Ganesh, again, and thanks for the opportunity to participate. Can you hear me?
Yes, and we see the screen also.
Okay, perfect. So this is a video about a robotic partial nephrectomy. This is a 66-year-old male radiation oncologist. He's a physician. And you see this tumor. The key thing I want to emphasize here is that you want to make sure that you want to have all the images. I mean, if someone just saw the middle image, he would have no idea where this tumor is. But if you look at the sagittal image, if you look at the coronal image, and then you look at the transverse image, the cross section, that's when you realize exactly where the tumor is. So I think it's critical to know to have all the three cuts when you are doing a partial nephrectomy. Moving on, planning is very important. This is the port placement. We have 5 XI robots in our institution. So we just do a straight line on the left side and on the right side. We don't have to do much out there. I think the key feature, especially on the left side, is mobilization of the colon. I can't overemphasize the importance of making sure that the whole splenic flexure on the left side is completely mobilized along with the left descending colon to make sure that the colon doesn't keep falling on the retroperitoneum and the hilum and other important structures when you're doing the main dissection. So it's very important to mobilize the entire left colon along with the splenic flexure, and you have to actually also go all the way up to the spleen, and there's always an attachment of the spleen laterally to the diaphragm. You basically cut that as well and mobilize the entire spleen as well, and that really helps, especially in obese patients. It helps with the colon not coming in the way. Then next, I don't go for the ureter. I go straight for the gonadal vein and trace the gonadal vein right up to the renal vein. As you can see here, just taking all the fat out. And then you go medial to the gonadal vein and go straight to the aorta and find the origin of the renal artery, like I'm doing out now. I really believe that your chances of mucking up and creating problems are much higher the closer you go to the kidney. So I tend to stay away from the kidney and go close to the source. So I go close to the aorta, you can see that. And all I need to know is just think about if you're eating your food. You just open your food enough to eat what you want to eat. The same thing, you just expose enough to put that bulldog clamp in the artery. You don't have to do too much more. And then once I do that, I go straight to the mobilizing the kidney. Coming to the anterior and posterior tumors, so like I said, I've done more than 1,000 robotic partial nephrectomies. I've never ever done a single retroperitoneal robotic surgery, and I can manage any posterior tumor you can give me without any problems with the transperitoneal route. It's just a matter of flipping the kidney. You can see the ureter you find here on the left side. You can see the ureter very well. Now I'm just mobilizing the kidney, going posteriorly. You can start seeing the tumor right there. You can see the tumor right here. So you see that, and you again mobilize the kidney completely. You cannot ever over mobilize the kidney. The more you mobilize the kidney, the more freedom you have in terms of getting the right angle that Janil pointed out, all the angles and the geography, if you will, of the tumor. Your ability to manipulate the kidney and put it into positions that help you do the tumor excision and reconstruction is much better if you mobilize the kidney. You can see this male, there's a lot of fat. It's not, this will be the definition of sticky, but not very sticky, to Sanjay's point. Now you are looking there. See again, I've just mobilized enough of the artery to put my bulldog clamp. You don't need to do more than that, just enough. So I always put 2 bulldog clamps, because I've found that 1 bulldog clamp doesn't clamp the whole artery completely. So I do that. At this point, you can see the kidney is nice and white. I will score the periphery of the tumor, and then I'll start cutting the tumor, as you can see here. So I'll start now, and then it is a combination of traction and counter traction. See what my left hand is doing. That's the most important thing. And see what my right hand, the fourth arm, the assistant, is doing. So my fourth arm is pushing the kidney down, and my left hand, as you will see, will keep on pushing the tumor up. So it's just a matter of traction, counter traction, and you just keep cutting down. I'm cutting here. And remember, this is even with a full clamp, it's relatively bloodless. It's never completely bloodless. And initially, when you start cutting, you'll always have some accumulated venous blood. It'll be out. But look, you can see all the structures that you want to see. You can see normal renal parenchyma. You can see the base very well, without any problems. You know that you are doing a good oncologic job while excising this tumor. You feel confident about it. And imagine if you had not clamped the hilum and you're doing all the crazy zero ischemia stuff, what advantage does it really give you besides making the whole field bloody? So you can see here, I'm incising the tumor out there. It's almost done at this point. And then you go all the way. Again, traction, counter traction, the tumor is done. You put it in the side on the endocatch bag right there. And now at this point, because it was a superficial tumor, I am only just doing one layer rhinorrhaphy. I'm not doing the 2 layers, but I'll show you in a subsequent clip that if it's a really deep tumor, you do the full 2 layers. So here I just did 1 layer because it was more of a cortical tumor, not going into the depth. So you can see here, again, see what my left arm is doing. You always remember, once you have experience, it just feels like you're doing open surgery with your 2 arms. I just do a running thing. I'm using the V-lock stitch. You can use any of these self-retaining sutures, the barb sutures. They're much better. And I just apply the Hem-o-lok clips along one line. And then once you do that, what I always do is I never cut the suture at this point in time. I will first unclamp. And when you unclamp, so you unclamp one and remove the clamp. And then the other one I'll unclamp and just make sure there is no bleeding. If there is some torrential bleeding or something like that, then you don't have to, I just unclamp, there is no bleeding, and then you just remove it. And if there is bleeding, you just reclamp back and take a couple of sutures wherever you need to do. And this is a different patient. This is a completely different patient. I just did this patient this last week. I did a heminephrectomy, a lower heminephrectomy. And this is if you have to do the suturing of the pelvic ileal system that I'm doing right now. You can see a laparati at the end of that suture. So I'm doing the pelvic ileal system at this point in time. And then I'll separately do the layer where just to take the blood vessels. So sometimes you have to take more than one suture layer in terms of doing the pelvic ileal system and the blood vessels, which I'm doing right now out here in this particular patient. So I did that, and the PCS is done, and now I'll go to do the rest of the blood vessels because it's a pretty large defect, as you can see here. And then once you do that, you do an external rhinorrhaphy. And in this case, the patient went home post-op day 2 without any problems. There were no complications as such, and all was good. Again, I'm just taking the blood vessels here. In my experience, most of the times in terms of complications, the one thing that you see, the more you do, the more complex surgeries you do of this, the more you see that more than the urinary leak, what I have found to be the commonest complication after doing a lot of partial nephrectomy is a pseudoaneurysm. That's something that is quite common but underreported in my humble opinion, but something that you ought to know. So here, like I said, I just did that, and then I'll do the second layer and they do it. Anyway, the warm ischemia time in this patient was 12 minutes. Adequate colon mobilization is the key. Good vascular control, complete mobilization of the kidney and flipping the kidney where you want prohibits or precludes the need to do the retroperitoneal approach where you are kind of limited in space. I just want to emphasize one thing on ischemia. Even though my study has shown that ischemia is safe, I'm not saying you clamp the kidney and just forget about it or take a break or do something like that. Most surgeries that we do in today's day and age, we will finish our ischemia time is around, less than 20 minutes. But occasionally for a case or someone who's starting off their career, and if they're taking 5-10 minutes more, it's not going to make a difference. But if someone is consistently taking 45 minutes to an hour to complete a surgery, and that's somewhere where you need some mentorship and some reevaluating of your technique, because that's just not the norm. So anyway, with that, I'll stop, and I'm happy to take any questions.
Thank you so much. And the tips were really so important for a posterior tumor. I think we had purposely given you that particular space so that you could tell us some things. I've seen you personally operate, and I have not seen any questions on the chat. So I'll ask you one question. I mean, I've seen you do it so many times. What do you think about using an intraop sonography?
Exactly what Sudhir said. So I only use sonography when I have difficulty finding the tumor. If there's absolutely completely endophytic tumor and you want to just find the tumor where you can make your markings on the parenchyma, that's when I typically use sonography for them. And I will tell you, if someone gives me an option between a nice 3, 4, 5, 6 centimeter tumor versus a very small tumor in a very fat patient, sometimes, and I've encountered this a couple of times in my career, that I've exposed the entire kidney and I've not found a tumor, and you still see an image on the CT scan.
Okay.
And those are the times when you then have to, use help of imaging.
Okay. So there was no other question. I mean, thank you so much. We'll move on to the next presentation, which is a combo presentation. It's to be by Dr. Ashok Hemal, who is a senior teacher faculty for us. And we all know he is a consulting uro-oncologist at Wake Forest Baptist Health Center. And we are fortunate to have him here also. So the topic is how to manage complex anatomy and hilar-renal masses, a hard talk. Welcome, sir.
Thank you. Can you hear me?
We are not seeing.
Yeah, we can hear you.
Okay. And let me. And can you see my presentation?
Not yet. Dr. Dipen, please stop sharing. Yeah. Dr. Dipen has stopped.
Okay. Can you see me?
Yes.
All right. All right. Good evening in India. First of all, I would like to thank you, Society of Genetic Urinary Oncology and Academic Uro-Oncologists for organizing this meeting. And thank you, Dr. Jagdish Kulkarni, President-elect Dr. Sudhir Rawal, and versatile Secretary Dr. Raghunath, Treasurer Gunil Kumar, and President Dr. Mallika Arjun, very versatile President of Urology Society of India. And Ganesh has put up an outstanding program with the help of Dr. Adla. So I have been interested with the duty of talking regarding the how to manage complex anatomy and partial nephrectomy for hilar-renal masses.
Yes, sir.
All right. So we have performed about 7,000 robotic procedures in Wake Forest since I joined here. And I have personal experience of above over 1,000 partial nephrectomies. So what is a complex tumor? So you ought to remember, these are the endophytic tumor, hilar tumor, or you are doing for the T1B or T2 tumor, multiple tumors, solitary kidney, or we are operating nowadays patient coming after failed cryo or radiofrequency ablation, or redo partial nephrectomy, or tumor in anomalous kidney such as horseshoe kidney or the post-transplant, and of course complex vascular anatomy and a bad fat around the kidney or the previous renal surgery and morbid obesity. So when you come across all these situations, what you ought to do, you have to do a very good pre-op planning. You have to be intraoperatively versatile, utilization of available tools, and be prepared to deal with the adverse situation. And you should inform to your patient well in advance and what's going to happen. Well, this is a very important chart for me when I do procedure. So these are the 4 factors. First factor is a patient, because you have to think about because this is a cancer operation. So first you have to think when you are doing procedure, say for example, T1B or T2 tumor, is there a competing risk factor for this guy, or the harms done by your procedures? So all these things you have to take into consideration. Thereafter, you have to assess the kidney, whether this guy has a chronic kidney disease, having proteinuria, or EGFR is low. Then you may want to consider opinion from the nephrologist before you go for doing partial. Also, similarly for the anatomy of the tumor, which is as a surgical understanding, because when you are going to do, this is the most important part you are going to deal at that point in time. However, the tumor biology and tumor aggressiveness is the predictor of your oncologic outcome beside the technical outcome, because you can only control the technical part, and the last is the surgeon and team factors. You should not underscore the importance of your assistant or the team. Suppose you land into big crisis, it is the team who helps you in that point in time. So we published our concept of the pentafactor in 2014, And usually you heard about the trifecta. These are all the jugglery of the words, trifecta, pentafecta. But bottom line is, trifecta is usually you talk about the immediate outcome, whether what was the ischemia time, what are but the long-term outcome depends on the quality of the nephron preserved and the quantity of the nephron preserved, which translates into the kidney function of these patients. So by and large, you should aim for achieving all the best outcomes for your patient, whatever you can do. So I'll go with the first patient. This is a patient who was a 58-year-old physician, and she was obese, diabetic, hypertensive, hyperlipidemia. And pre-op imaging, you can see she had a T1A tumor, and it was a purely endophytic tumor close to the hilum. And basically she saw a couple of urologists. She came from another academic center for talking about the partial with us. And because of the location, you cannot do the radio frequency ablation or cryoablation because it's close to the hilum. And she was given option of the nephrectomy. But again, we talked to her that I can offer you doing a partial nephrectomy. But still, I said there is a possibility I may convert to open procedure. Also, there is a possibility of radical nephrectomy. So what I'm trying to say, if there is a doing a complex cases, always talk to the patient. Conversion to the open surgery and conversion to the open partial, not the radical nephrectomy. If you can do open partial, you ought to do that. If not, only then you should consider radical. Now, this is the port placement, is a standard port placement. Unfortunately, some of the people, they don't have XI robot, but with the XI robot, this surgery has become much, much more easier. So this is the, I'm just trying to show a small clip because so this is, I just straight go to the hilar area after mobilizing the colon. Here you can see this is a renal vein. And I used, the fenestrated bipolar in my contralateral hand because the tip are not sharp. Then you're trying to find out the renal artery. And I observe a lot of people, they try to denude the vessel, they try to skeletonise, which is not necessary. In my opinion, as long as you can make a 360-degree window around the artery and vein, you should try to do. In my practice for complex cases, I do like using ultrasound, and I think it is an excellent tool for doing a complex partial nephrectomy. And there are several reasons for doing that. So now you can see the image. It's not about only seeing the outer surface or scoring. It's about how deep it is, what is the relationship with the in the renal sinus, and what is the trajectory. So when you are going to cut this tumor, then you can figure out how deep you have to cut, which way you have to go. So that's the advantage of doing a ultrasound in these cases. So there are one region, anatomical location. Second, you can plan your trajectory for doing these cases. Third, you can see the vascularity of the tumor. So these are various advantage of doing ultrasound after figuring out where tumor is. Some of the situation where, I have done 3 cases where the outside surgeon, they tried to do a partial, but they could not find the tumor. And then they were referred to us. And the BMI was almost 50, 60, but ultrasound was helpful. Now, I don't want to do too much scoring. I just do a start with the cold cut. So you saw, I did not do a scoring because I don't want to burn. And that's not necessary. Then I cut all around the tumor because I have planned very well by understanding the anatomy with the help of the ultrasound. Here you can see, I'm trying to go to the base of the tumor because this tumor is getting into the renal sinus. So I have to cut void at the renal sinus area. So here you can see this is a renal sinus fat. I'm going through that. And so the concept of the resection and enucleoresection, because when you are close to the renal sinus area, you cannot have a normal parenchyma there. So you ought to do a nice enucleation, but whatever you're resecting at the base of the tumor, it will be paleocalcium system or the small blood vessels. So that's how you have to remember. So in the complex cases, you should go with the open mind of enucleoresection. Also in these cases, it's hard to preserve the normal parenchyma on the top of the tumor because these are pure endophytic tumor. So as you saw, I took a very wide margin of the upper cap. So the normal parenchyma on the top, there's no way I can preserve. Now coming to rhinorrhaphy in these situations, now you see the step 1, because as I said, this was a tumor involving the sinus. So I have to cut void in the paleocalcium system. So I'm trying to close the paleocalcium system. So in a complex tumor, you have to do a 3-tier repair of the rhinorrhaphy. So first tier, you are working at the base of the tumor. So at the base, you see the pelvic calcium system or the small vessel, or you cut through the artery or cut through the small vein. So you have to take care of those components at the base of the tumor. So this is an example of doing the first layer. Thereafter, I start with the second layer. In second layer, what I'm trying to do, you are trying to take the little bit edge of the renal sinus fat, and you are taking a corticomedullary part of the kidney, because there's no way if I try to do, because you see the big gap. So it is a big saucerized gap. So in order to cover that gap, this is the second layer where I'm taking a sinus fat and I'm taking a part of the corticomedullary area, because there is no way I can close in one layer. And if I try to close with the interrupted suture, then I'm going to leave a potential space in between. So once after doing these two layers, then I put an interrupted suture to do a complete the rhinography. Now clips, what you are seeing, these are the absorbable clips. So all these white clips, what you are watching, they will get dissolved over a period of 3 months. So these are known as lepro clips, and these are made up of the polyglycolic acid, and they get absorbed just like a polyglactin material for the leprotide clip, which you see the blue clip. So this is an example of pure endophytic tumor, and rest of this stuff, just closing these areas and again putting those interrupted sutures, and so you can see, then you can cinch it nicely. So this is, now it has come out nicely. Now moving on to so the final pathology in this physician turned out to be the clear cell renal cell carcinoma, 3.5 centimeter was size of the tumor. But if you look at the excised tumor size was much more than 3.5 centimeter size of tumor, where, as I mentioned to you, because you have to take out a normal parenchyma above the tumor, and there is no way to figure it out where exactly go despite doing ultrasound. And post-op treatment was appropriate, and she was discharged on day 2. Now, so in summary, when you are operating on endophytic tumor, you have to be very cautious, and you have to be aware about the different factors such as toxic fat, medical comorbidities, morbid obesity, and try to lose as much as, not to lose as much as parenchyma. So means you try to preserve good quality and quantity of the parenchyma. Now, next case I'm going to demonstrate. This is a 73-year-old African American male who had, the solitary kidney. This guy has undergone radical nephrectomy almost in 2009, and he had a T1B tumor, which was a 5 centimeter in size, and this was referred to us. So again, we did a shared decision-making, talking to this patient. I got him seen by the nephrologist also, because say, suppose I end up doing a nephrectomy, or I end up doing a the problem AKI, patient develop AKI, then he may require dialysis after surgery. So being a solitary kidney, I try to do all those factors. Now here you can see, this is the left solitary kidney, and this is a tumor. So you can see all this tumor, endophytic tumor, and going up to the renal sinus, and this is another image you can see. Just mostly posteriorly located tumor, and mostly endophytic tumor, African American guy with a little bit toxic and adherent fat. So due to want of time, I'll just go straight to the tumor. I do not dissect ureter and all. I mean, just go straight to the hilar area. If required, you can do endophytic, you can do a little bit dissection around the lower pole of the kidney. Now, what you are observing, I have done the ultrasound already in this case, but basically what I'm trying to say, this is a technique, transperitoneal technique for doing a posterior tumor. So basically, when you want to do a transperitoneally posterior tumor, you ought to mobilize kidney completely so you can flip around you. And the bottom line is you should be able to see all around the tumor. Now my forearm, you can see the assistant is retracting with the suction, and I'm using my left hand to lift the tumor so I know how far I have to go, how deep I have to go. And in the sinus area, definitely you cannot save the pelvic system. Because if it totally stuck to that and you want to have a negative surgical margin, you ought to excise, and you should not hesitate in that. And wherever it is a solid, there you can peel it off from the normal parenchyma. So this is how you do this is a transperitoneal approach for the partial nephrectomy for the posterior tumor in a solitary kidney. So again, and I observe in the African American patient, the fat is very sticky, very toxic. I'm sure Dr. Parekh does, same way, and he come across a much more worse cases in this scenario. African American population, they are more obese and they have a little bit more toxic fat in comparison to Caucasian. And here again, I'm showing that 3 layers technique. I believe in a large tumor, big defect where you get into pelvic calcium system. I believe in doing a 3 layers technique, and basically I'm trying to do a sinus part. And this is after doing a sinus part, then you can go to the corticomedullary part. The reason for going in a 2 layer for the cortical part, because the renal parenchyma thickness itself is about 3 centimeter, and the needle size may not cover with the one pass that whole 3 centimeter edge of the parenchyma. And if you try to do, then you leave a potential space at the base of the repair. So therefore, you may want to do a different way. So this is an example of the transperitoneal approach for the posterior tumor. And on this guy, the pathology was the T1B, G3, and the tumor dimension. Again, you can see the tumor part was 5.5 centimeter, but the excised part was a centimeter all around. But that is again because of the uneven edges of the tumor and getting into the sinus, and it becomes very difficult to figure out to save only 3 millimeter margin or 5 millimeter margin. Now, the third case I'm going to show, this is a posterior approach for the solitary kidney for the T1B tumor. Again, this guy has undergone, the radical nephrectomy few years back outside. Then he was referred to us because he was having solitary kidney. BMI was 31, and these are the images. So this was a posterior tumor. So I decided to do a posterior approach for this tumor. And again, this is the standard flank position, what you do routinely for your other procedure. And we make a space, create the extraperitoneal space just going above the iliac crest, about 2 centimeter above the iliac crest. And in India, I know all of you guys do a fantastic job creating retroperitoneal space. And this is, placing the balloon trocar if you have availability. Otherwise, the advantage of balloon trocar, you can put a camera and you can see under vision. And this is a 12 millimeter robotic trocar, or that you can put an adapter and then you can use an 8 millimeter camera. Now here you can see I'm going posteriorly. Now it is a posterior tumor solitary kidney. And in fact, in this case, first I tried to put an ice. I wanted to do under cold ischemia, being a solitary kidney, but it was so cumbersome, and I dropped in between the procedure and straight moved to the warm ischemia. And this is the, you can see I'm trying to go close to the kidney area just to figure out where it is, because it was an obese guy, as I mentioned to you, and he had a lot of fat, and he had beside radical nephrectomy, he had a 2 abdominal surgery on the colon. So now the advantage is I reach posteriorly and I can see the renal artery right there. But you will see as I advance, but I'm too close to the hilum, and I realized that this may not be the main primary renal artery, and I may be too close to the hilum, and I might be dealing with the branches at that point in time. So with the fourth arm, I'm lifting the kidney, and with my left hand, I have the bipolar, fenestrated bipolar, and right hand, I have a seizure. So I decide to go down because I thought there may be accessory arteries, and that if I clamp the one renal artery, that I may not be able to control. Typically, I do not control the renal vein. I just put a clamp on the renal artery, and your effort should be try to go as proximal as possible. So the advantage of missing the accessory artery or the additional artery is very less. And I'm sure all of us, we visualize look at the renal, the CT imaging or the cross-sectional imaging, but despite that, we miss sometimes we can miss the structure. So therefore, the bottom line is you try to go as proximal as possible. And I personally believe in only renal artery clamping. Renal vein clamping is not necessary, but I will not say no, but if required, you can do that. That's not a problem. Now here you can see I'm very close to the posterior hilum. So this is a posterior tumor, very well exposed. And now I'm doing an ultrasound. The region for ultrasound, again, this way I can see the little bit spatial anatomy of the tumor and also even make a mark. But then you have to decide what should be trajectory for the cutting this tumor. Because if you cut it straight, you can get into a tumor. If you cut oblique, then you have to figure out you might not be taking more parenchyma. So that way, at least it gives you a cognitive picture to you. How do you want to cut this tumor all around? So that is the advantage of the ultrasound. Personally, I believe using an ultrasound in all my complex cases. Now here you can see now I'm putting a clamp over renal artery alone. And and I put it too clean because being a solitary kidney, I was really worried that I should not get into problem. Then I'm giving a indocyanine green. Usually I give a 0.5 to 1 cc indocyanine green just to make sure there is enough ischemia to do what I'm trying to do. Because if indocyanine green shows a very green kidney, that means we really missed a big artery. But here you can see there is a brisk bleeding. So this is the venous bleeding, and this is could be a backflow. And the reason is that we have not clamped the renal vein. Also, there is a lumbar vein. So always there can be backflow or the contained blood inside the kidney before clamping the renal artery. But you need not to worry. I was, this was not much bleeding to my mind, so I decided to continue with that. And so this is just giving an example of the retroperitoneal approach for T1B tumor in a solitary kidney. And the principles are same. You try to stay close to the tumor, taking some margin around that so you don't get into the positive surgical margin. As again and again, I keep saying this is a cancer operation. You need to avoid the positive surgical margin. Don't worry about the bleeding too much. Worry about the cancer and worry about the positive surgical margin. That is the most important, and that is going to give you a long-term oncologic outcome for your patient. So this is what I did. So you can see the tumor exercise, and again, after that, there's a little bit venous ooze. As I said, that back bleeding, not clamping renal vein, these things you have to take into consideration. But as I said, I believe in doing renal artery. And then again, this is a 3-layer closure, as I showed you earlier. So the first layer you close at the the base at the renal sinus, then corticomedullary and cortical junction. So I tried to, as I mentioned to you, I tried to do a cold ischemia, but I was not very happy, so I gave it up in between. So that's why the warm ischemia time was 30 minutes in this case, or time was 3 hours. Post of this patient developed AKI, his creatinine was 2, and if you saw previously it was 1.1, but post of AKI was there. But he was discharged on day 2, and in a month his creatinine came back to normal, and it was a 5.5 centimeter tumor, clear cell, RCC grade 3 with margin negative. So why pick a retroperitoneal approach? So in my practice, almost 90% cases, maybe 85% cases I do with the transperitoneal approach, but I do in 10 to 15% cases the posterior approach because of some of these cases are hostile abdomen, multiple abdominal surgery, or posterior tumor, posterior hilar tumor, posterior big tumor. In those cases, I do in the retroperitoneal partial. So the key message for this part, I would like to give a decision should be based on the approach and tumor location, and also surgeon comfort in doing these kind of technique, which you will be more comfortable doing that. Pre-operative planning for the complex tumor is extremely important. You may want to understand the cross-sectional imaging, what you are doing. Also, I personally feel it is very important. It is a patient, so you have to think about the competing risk of medical comorbidities, surgical comorbidities, and also the competing risk factors for doing what you are doing. And there should be informed consent for these guys. And also, you know your instruments, you know what you can do. Also, you prepare your team well and prepare a rescue tray in case required. Be ready for the variation when you get into these cases. It's not that you're going to have a G portion. You have to be aware that maybe a serious adhesion, serious bad fat. Sometimes you end up dissecting fat for 1 hour, 1.5 hours, and rest of the surgery can be 30 minutes. So, but well preparation is very important. Exposure is extremely important. So these things are very important. And now technical tips, what I will say, when you are cutting into the sinus, cut wide and deep into sinus fat, again to prevent the negative positive margin. Also, I believe that when you are doing complex cases, you don't mind taking a wider margin, minimize traction so you don't rupture the tumor. And also, endophytic component is very important because this avoids the sinus fat. And the concept of the early unclamping is important, especially after doing your suture at the base area or the sinus fat area at the most corticomedullary area. But you should not unclamp after completely closing the renal, completely doing renal-raphy. At that point, there's no advantage of unclamping. Only advantage if you get to know there is a bleeding, you have to cut out your all sutures and you have to redo the renal-raphy. So if you really want to take advantage of unclamping, do after doing the basal layer, and then you can do an unclamp and you can see for the bleeding. And if you need to, take care of it, do that. And these are the intraoperative bleeding. I'm running out of time. So these are some of the strategies for preventing the positive surgical margin. Review images for the size, location, depth of the tumor. Vascular control is important. Dr. Parekh has done a seminal work in this area. And, this was a great, work done by Dr. Parekh. And that has proven that 30 minutes, no worries, even cross 30 minutes, not to worry about that. So don't worry about too much about the ischemia time. I do recommend that ultrasound is a very good adjunct tool in these cases. And I believe in using indocyanine green for several reasons. Number one, sometimes if they're difficult to find the hilar dissection in the bad fat, you can give indocyanine green. You can identify artery and vein. Also for the tumor differentiation, if you give a 0.5 cc ICG and see there is a differential uptake of ICG between the tumor and the normal parenchyma. Also at the end of the procedure, you can again give a little ICG and see the margins are not ischemic, because if your renal ref is too tight, the work from Dr. Sundaram, who has published that tight renal ref can lead to renal ischemia at the edges of the parenchyma. Though it translates into the CKD or not, I have no idea, but definitely you can prevent by looking by the ICG. So with this, I would like once again to thank you, Society of Genitourinary Oncologists and Academy of Uro-Oncology, and I'll be happy to answer any question if you have.
Thank you, sir. There are a few questions like, is the posterior approach on the left side same as the right, or is there anything different, special tips for that?
No, basically the reason is that, as I said, I do not clamp the veins, because the vein issue is if you're trying to clamp the vein, so you should be aware about the lumbar vein. And sometimes the lumbar veins may be more on the right side in comparison to the left side. So those things you have to keep in mind. Also, the bilas right side may be a little more tight space in comparison to the left side when you are doing a retroperitoneal approach. But definitely, fourth arm is very important in these cases. And with the XI robot, it's very easy to place the fourth arm when you are doing retroperitoneal partial.
Okay. There's one more question we would like to ask you. If clinically it is a T3A going in the renal sinus, what is your opinion? Would you go for a partial or would you go for a radical if the other kidney and overall the GFR is good?
So, this is a very good question. This is a very theoretical question, what you are asking, because you don't know beforehand it's a T3A. If you know beforehand it's a T3A, the very standard guideline, if you can maintain the eGFR after doing radical nephrectomy more than 45, you can go ahead with the radical nephrectomy. But most of the T3A diagnosis we make after doing a partial nephrectomy. As I showed you, those both, two T1B cases, they are going to the sinus. And I was concerned and I talked to both the patient that there could be a T3A situation. But the bottom line, these guys have a solitary kidney. You want to preserve the nephron. And now there's a lot of data on T3 that you can give a neoadjuvant, even the checkpoint inhibitor or chemotherapy downsize and then do the surgery.
Absolutely. There's a question from Dr. Lal Malani. Why clamp artery only? Why both artery and vein together separately? How?
Yeah, so there are two, it's a very good question. So the reason for doing that, number one, there's no need for doing, because suppose there is an accessory collateral blood supply coming to the kidney, then your kidney will become ischemic and it will increase more, you lose more blood, Number two, sometimes because we have seen accessory artery, tiny artery, or the coming from here and there. So the first thing what you try to do, unclamp the vein. So why do that? And we have published, there are two papers. We have published initial study of 212 patients, I think in 2012. And then we published 453 patients comparing the zero ischemia, renal artery alone, and the renal artery and vein. I don't call it zero ischemia because always when you do a laparoscopy or pneumoperitoneum, there is ischemia. So there's nothing like zero ischemia. I say unclamp technique. So unclamp technique, if you do for the chips or tumor, the recovery, this loss of the GFR is very minimal, but that is only for 2 weeks or 4 weeks. But renal artery and vein you do, there's a more loss of GFR with renal artery and vein in our study in comparison to renal artery alone. But all of them, they recover if you follow these patients 6 months out. So which is why I try to do only renal artery alone. Also, when people, they try to do a renal vein, sometimes you hit inadvertently the tiny vessels around the renal vein.
Okay, thank you, sir. We'll proceed to the chairperson. Respected chairperson, please give your expert concluding comments and takeaways. Dr. Mallikarjun and Dr. Anand.
Thank you, Ganesh. Wonderful session on technique-related issues in managing renal cancers. First talk was of Sanjay. It was, am I audible?
Yes, sir.
Yeah, okay. First talk of Sanjay, wonderful Sanjay. It is a usual thing which we started looking into now, wherein we start looking, we have been practicing robotic and we come back and start doing the open surgery, and the difficulty is what we start feeling it. And majority of the times we see, we replicate the same robotic steps into the open. We have forgotten the open surgical steps and we replicate the same robotic steps coming into open surgery. And the only one point which I wanted to add was, if at all you start doing open surgery, better wear a loop, because you got used to that sort of a magnification onto your robotic. You start get lost because you start don't realizing what is the anatomy there. So I think the best thing is to wear a loop, and you will be able to do that. And your point of learning continues is always wonderful. But I think if you start doing even open surgery, I don't think it will be the same results like what you have seen 10 years ago, because the protocols have been different and the way the patients are being managed are different. The visibility and our experience and our learning has changed the whole dimension of surgical results of late. Coming to Ginil's talk, Ginil has doing an excellent work on fantastic pictures. Ginil, I think one of the wonderful pictures I've recently seen regarding the laparoscopic partial nephrectomy. I've been doing it very often past 10 years now. I've shifted to robot, but two things which I say, all these renal scores, Padua scores, all tell you the complexity of the tumor, and you should understand what makes it complex. That's more important. You see, these scores will make to understand, to compare with some other group, or to give 100 cases this way, 100 cases that way. But what you need to understand at that one single particular patient is what makes the tumor complex for that day. I think that analysis has to happen. There's no point having written on the renal score 10 on the board and not understanding what makes it complex at that point of time. So I would say for anybody who wants to practice laparoscopic partial nephrectomy, the margin of error is going to be very narrow. So in which case you better understand what makes it. Write down those points, what are the complexities are, not the score there, which is most important. And second point, which I always say, is regarding technical aspects, what he has covered. Second thing is, once you come back from robotic lap, you align the kidney towards parallel to you. That makes your job easier. It is not about suturing. It is about cutting the kidney also, cutting with your scissor also. So make your scissor parallel to the kidney. Mobilize the kidney in such a fashion, that much only, so that it is parallel to your instruments. This is one point which makes the difference regarding the result of laparoscopic partial nephrectomy is concerned. Now coming to wonderful talks from Dipen and Ashok, I don't know. I was wondering about this. We are all having those numbers without 10 at the end. So you said 7,000, 4,000 here. I said, okay, take out one numbers and restrict ourselves to 400 or 700. And phenomenal talks. And I think they have extremely well, and their experience has shown how to do a difficult partial nephrectomy and how to look at ischemia versus oncological outcomes. That's the most important thing. Majority of the times, the ischemia part gets over and over emphasized than oncological clearances and not getting a positive surgical margins. Two small points. One thing anyway, robot will definitely give you a flip of the kidney, will get you wherever you want. Majority of the times, I personally, I don't know, till now possibly Dr. Ashok, Dr. Hemal was talking about a kidney where there are multiple surgeries in the abdomen is one specific good indication for retroperitoneoscopy. But I would say, unless you are trained or you have been done once or twice before in a laparoscopy, don't just jump onto doing a retroperitoneal surgery. It is not so easy. You have done it before, you are experienced with it, yes. But don't do it just because it is one way of doing a robotic surgery. That's one thing. Don't jump on it, please. The margin of error is still narrower than a transperitoneal laparoscopy. Flipping the kidney is going to be the best way if you want to do a robot in case if it is there in the posterior aspect, or even a rotation of it is going to be done. And second thing is this 3-layer technique, what Dr. Himal was showing it. It's a wonderful technique. I think I have a little difference possibly in my way of controlling my pedicles or possibly the hemostasis in the bed. I would always go for independent suture ligature, and a small technique is don't clamp the vein, give a Valsalva maneuver for the ask the anesthetic to give a Valsalva or increase the intrathoracic pressure. You will see the veins bleeding out on the bed. And that will show you where those artery and vein complexes are there in that bed. And an independent ligatures in that area is going to save, because the depth where you can injure the rest of the arteries on the other side is going to be very narrow. So in a Valsalva and independent ligatures in the sinus bed and the rest of the 2 layers or 1 layer, whatever is want, will give you safety regarding not damaging the rest of the arteries. I think this is what I could read, but an excellent overall technical discussion what has happened regarding doing a partial either robotic or shifting on to open, or even this thing. And one very good point both from Himal and Dipan was, don't dissect too much of an artery. You need only a little area, and that too near to the aorta, so that you can keep a bulldog and keep it away from your equipment. Keep it away from your instrumentation. One of the biggest dangers which happens is your instrumenting dislodging the bulldog, and that should not happen. So keep it away. So go towards the aorta and have a clamp on it. I think Anand, you can take over from this.
Yeah, thank you, Dr. Mallikarjun. I think you've covered most of what I wanted to say, but there are a couple of points that struck me in Sanjay's talk. Very, very nice talk, Sanjay. You talked about centralization, and I think that's the need of the hour. We need centers of excellence where people are doing relatively higher numbers of partial nephrectomy rather than just 1 or 2 a month or something like that. So I think that's a very, very valid point that you made, Sanjay. And next, going on to Ginil, I think the first thing that he said was a roadmap of the tumor. So a lot of times we find ourselves looking at the pictures of the tumor and doing it, but ideally I would suggest, like Ginil said, get the CD of the CT scan and then put it on your PAC system and review it several times before doing a partial nephrectomy. I think that's a reasonable thing to do. When Ginil said the angle of cutting the tumor and the angle of suturing is different, and that's a very valid point. So good mobilization, moving the kidney whichever way you want when you cut and suture, I think is a fantastic technique. And he finished off by saying know your limitations. I don't think anybody will disagree with that. So very good, Ginil. Next is a masterful talk from Dr. Parekh. And again, exceptionally good demonstration of how a difficult posterior tumor should be done. So traction, counter traction, and a good mobilization. And Dr. Himal's talk, again, such a senior surgeon, he emphasized that he would counsel the patients about converting into open radical nephrectomy or open partial nephrectomy. And coming from such a senior surgeon, I think it's all something that we should all take it. So that, there's all patients should be counseled that these are possibilities when we attempt a partial nephrectomy. And that's a very, very good thing to do. And he also demonstrated that we should be versatile enough to shift our approach, either retroperitoneal or transperitoneal based on the tumor. Again, I learned a lot. Thank you very much, Ganesh, for organizing such a nice session. Thank you, all the members. Thank you.
Thank you so much, Dr. Mallikarjun and Dr. Anand. Before we hand over to Dr. Raghavan for the panel, Dr. Jagdish Kulkarni, sir, President, wants to make 2 quick comments. Sir, you have to unmute yourself. And
to make it at the end, but I think I'm just thinking there have been some questions about what is this society. A lot of inquiries are coming to me. I am here to tell you that the society has been formed and it is in the process of registration. It will take about 2 weeks from now, and in a month's time we should be in a position to give you all the details of the society to all the delegates and to all the Urological Society of India members. Thank you very much. This much only I wanted to say.
Thank you, sir. Dr. Raghavan, it's all said to you. We are sorry, but delayed by 10 minutes odd. But we still could have a very good panel completely with you because you're very well prepared for it. Thank you so much.
Thank you all. Hope you guys can see my screen and hear me as well. Can I start?
Yes, please.
Thank you so much, Sanjay and Ganesh, and especially Kulkarni sir and Sudhir sir. It was just amazing to have such a wide range of people, especially Deepan sir, Ashok sir. Thanks for comments from Mallikarjuna, Anand. It was really enlightening. Thank you so much, and I'm hoping that our audience are enjoying it as well. We shall move on to do some practical talking with our panel. We have Dr. S.K. Raghunath, Senior Consultant Uro-Oncologist, Trustwell Hospital and HCG Bangalore. Dr. Hemant Tongonkar, Senior Consultant Uro-Oncologist, Hinduja. Dr. P.B. Singh, Senior Consultant at Yashoda Hospital, Ghaziabad. Dr. S.K. Singh, Professor of Urology, PGI, my teacher as well. Dr. T.B. Yuvaraja, who's a Senior Consultant at Kokilaben. Dr. M.A. Salam, Senior Consultant, very famous uro-oncologist in Bangladesh. Dr. Srivatsa from Sri Shankara Hospitals and HCG. And Dr. Rahul from TMC Mumbai. We have an eminent panel, and we are going to try and sort of unpick all the nuances with the small renal mass. This is a 24-year-old female who presented to me with a non-specific loil pain. She was investigated and found to have a small abnormal area in the left kidney. 2 years ago, the CT plane was done and is suspected to be a complex cyst and was kept on ultrasound follow-up for 2 years. So the first question is being thrown at S.K. Raghunath. Raghu, is it justifiable to just observe these things, or should we, go it on and characterize it further? Is active surveillance an option for small renal masses?
Thank you, Raghunath. It is definitely justified to observe small renal masses, but in this particular case, she is just 24 years and only plain CT has been done. So these two parameters we should consider. So ideally, we should get contrast CT, and as discussed with you, contrast CT was done later, and it was type 3 Bosniak cyst. In this 24 years old lady with Bosniak type 3, probably I would consider some active treatment. I would not go for observation. And you also asked me to cover up, what is about active surveillance.
Yes.
So to understand this active surveillance, we should understand the natural history of small renal masses. Small renal masses, I mean less than 4 centimeters. 25 to 35% of small renal masses do not grow when observed over a period of 3 to 5 years. Of course, this is Western literature. We don't have Indian data, and no correlation identified between size and growth rate. Meaning to say 1 centimeter and 3 centimeter, when we compare, sometimes 1 centimeter can grow faster than 3 centimeter. And risk of metastasis is very, very less, maybe 1 to 1.5 centimeters when it was observed over a period of 5 years. And average growth rate is around 2 to 4 millimeters per year. Meaning to say, if the growth rate is more than 5 millimeter per year, that is fast growing. Otherwise, this is relatively slow growing. Can I have my next slide? And to understand this as well, we should try to understand the pathology of these small renal masses. So you see here, less than 4 centimeter, I have taken from Mayo Clinic and UCLA. Most of these tumors, at least 20% of these tumors are benign if the size is less than 4 centimeter. In our Indian data, we don't have Indian data, but in at least our series of more than 300 partial nephrectomies where we have done both open and robotic, 1.5% of our tumors are benign. So which is very less compared to Western data. And when it comes to the tumor size and grade, most of these small renal masses, at least in this particular series, 86% of them were of low grade. Meaning to say, these were not very aggressive tumors. And next slide. Yeah. So this is the average, growth kinetics of small renal masses from the SAM registry. It's about 2 to 3 millimeter per year. Next slide. So I've taken all these guidelines and put it here for your better understanding, particularly for postgraduates. So what are the patient characteristics we should understand for absolute indications to observe or to enroll them for active surveillance is then the life expectancy is less than 5 years. 75 or 80 years old person with a lot of comorbidities, if he comes with say 2 centimeter or 3 centimeter renal mass, we are not going to do partial nephrectomy for them. And if they are high risk for anesthesia or surgery, even if you are planning to do partial nephrectomy, if they end up with some complications, we don't like to go for active treatment. So active surveillance is one of the options for them. There are other relative indications. I would not go into the details of those things. And tumor characteristics, please go back. The tumor characteristics are very important. It should be less than 3 or 4 centimeters. And preferably necrosis should not be there. If necrosis is there, chance of having high-grade tumors are more. And even the guidelines suggest that biopsy is required in these patients before enrolling them for active surveillance or observation. And abdominal CT or MRI, and some series even suggest CT chest before enrolling them for this active surveillance. And follow-up, you need CT or MRI or sometimes even ultrasound can be employed. In the first year, probably we may have to do every 3 monthly, and the second and third year twice yearly, and fourth year onwards every annually. It is required to understand whether it is a slow growing and fast growing. If it is fast growing, probably we should consider them for active treatment. So only triggering factor here is more than 0.5 centimeter per year growth rate. Of course, all these things we have taken from Western literature. We don't have Indian data. Next slide. So to conclude, to summarize, active surveillance or observation is definitely indicated in small tumors, indolent tumors particularly. So meaning to say, indolent, how do we say? Or by following up for 1 or 2 years or 3 years, understand the growth patterns, then we can say indolent tumors. And imaging is very crucial to evaluate and follow up. Biopsy may still be necessary, particularly in solid masses. In cystic masses, probably it is not of any use. Active treatment should be considered in young individual, as Dr. Raghavan said, in this particular case, 24 years, we should consider active treatment, or if the growth rate is more than 0.5 centimeter per year. In this particular case, I would probably consider surgery because she is 24 years and both neck type exists. Thank you.
Thank you so very much, Raghu. I mean, the take-home message is that active surveillance is something could be considered, but one should be very careful when you put these patients on active surveillance. Extremely strict follow-up protocols are necessary. Yes. A biopsy will be mandatory for these patients before putting them on. Now, Raghu touched upon a point that this patient, when she came to me, had just a plain CT. So I want to highlight what is the appropriate imaging for small renal mass. For this, I'm going to invite Dr. Srivatsa to tell us more about this. Sri?
Yeah, good evening, sir. I think we can go with the next slide straight away. And the question, the answer to the question is that plain CT is just not enough. So coming to the imaging of small renal masses in particular, mandatory to have some sort of cross-sectional imaging, either the CT or the MRI. And by and large, cross-sectional imaging is preferable with a CT scan unless it's contraindicated, or where the tumor size is less than 2 centimeters, where a contrast-enhanced MRI might have a better imaging description, or probably even lead us to a histological diagnosis. When we order for a cross-sectional imaging, it is beneficial to request the radiologist to perform a baseline metastatic screening as well. Also, very important is to note that we request the radiologist to image the patient with an angiogram protocol, that is the arterial phase, the venous phase, as well as the delayed phase, especially in a small renal mass, which will help us greatly in contemplating the way we need to approach these tumors. I would like to highlight here that it's kind of become fashionable to order a PET scan in all tumors. So renal masses and small renal masses in particular have very low PET avidity and should not be requested unless there is a strong indication to do so. Coming to the next slide, go back, sir, please. Coming to the evaluation of cystic lesions, one point that I wanted to highlight here is that the slices that we request the radiologist to acquire in a cystic lesion should be at least 3 mm or less. Whereas for an evaluation of a small renal mass, it can be even as high as 5 mm. But for identifying the subtle enhancement within the cystic lesion, 3 mm slice or less is preferred for evaluation. Another point about the SPECT CT, not the PET CT, is that there are 2 papers now which have shown that whenever oncocytoma is suspected as a small renal mass, a technetium 99 SPECT CT can be employed to differentiate an oncocytoma from a low-grade chromophobe RCC. Can we move to the next slide, sir? Yeah, coming to the tumor-specific factors for choosing the imaging, tumors less than 1 centimeter typically are observed, but if we are contemplating, treatment, active treatment, an additional imaging is mandatory prior to intervention. That is, if a CT scan has been done, it's probably worthwhile to do an MRI before we, take a decision on intervention. Tumors between 1 and 4 centimeters will go through a standard evaluation, and tumors between 3 and 4 centimeters typically, or like what Dr. Raghunath mentioned, those tumors which show necrosis as one of their characteristic feature should also have a comprehensive metastatic evaluation. Next slide, please. Tumor complexity, I think it has been highlighted. I don't think I will go to it. I mean, it's mandatory that, every imaging should have at least one of these scores mentioned with it, which will help us decide the way we approach the case. Next slide, please. This is another small thing that I wanted to highlight. There are many times where we find that, patients with small renal masses come to us with compromised renal function. So understanding the eGFR of this patient is absolutely necessary. In fact, eGFR should be mandatory in evaluation of all renal masses. DTPA renogram should be performed whenever we suspect that the contralateral functioning unit is not functioning up to the mark. And whenever the renal function is compromised, contrast enhanced ultrasonography is a very good tool. Unfortunately, not freely available in India. And wherever contrast enhanced ultrasonography is not available, MRI without contrast is a very good alternative, but we need to specifically request the radiologist to give us his opinion about the image characteristics based on the DWI as well as the ADC.
Sri, I thank you so much. So the take-home message here is that a standard evaluation requires a contrast-enhanced CT. Almost all centers in the world, including India, are doing 0.1 mm cut or thin slice CTs, and therefore it should be the mandate, and therefore it is our duty to demand that from the radiologist. A metastatic workup has to be done when you are having a tumor close to 4 centimeters, especially with a necrosis in between, in the middle of the tumor. Am I right, Sri? Is that?
Yeah, absolutely, sir. Absolutely.
Okay. Sri, I have one question that was raised by one of the viewers, is that even though it is not directly related to the evaluation, in the follow-up, a lot of CTs are being done. A patient with a small renal mass who had a partial nephrectomy and has a series of CTs, say 3 to 5 CTs in the 5 years, are they going to put themselves at increased risk of secondary malignancies? What are your takes?
Secondary malignancies, yeah, there is definitely going to be an marginal increase in the risk of secondary malignancy. But doing one CT probably once a year may not actually contribute to an increase in the risk.
Okay, thank you. We'll move to the case scenario. So after 2 years of observation, there was a slight increase in size, and the plain CT and MRI was done by the referring team, and it showed a complex cyst / hemorrhagic cyst. They did an FNA as well, which was not diagnostic, and at that point, a patient was sent to me with an FNA report. That brings us to the next question. I'm going to request Professor Salam to talk on this question about an FNA / biopsy of a small renal mass. Where do we stand at this point of time?
Thank you very much. It's a very important area where we should concentrate. The detection of the small renal mass is increasing throughout the whole world. And imaging modalities with ultrasound, contrast CT, MRI, contrast ultrasound is unable to accurately categorize the tumor. And in that situation, we need to have a biopsy. So biopsy is recommended for all the renal mass which are very, very suspicious. And among the surgically treated small renal mass, about 80% are going to be malignant. But also interesting to note that low-grade, early-stage tumor and with low metastatic potential is commonly seen in this scenario. And 20% of the tumors are benign. And that benign tumor may include the low lipid angiomyolipoma, oncocytoma, lymphoma, and the secondary tumors, the sarcoma could be another one, and there could be even benign lesion like abscess or something like that. So we had to be very careful. Very good imaging that has been emphasized very clearly. And we also understand that about 80% of the small renal mass are malignant. We would have to remember 20% are not malignant. And also there are cystic diseases which has to be reminded, because the cystic disease, if it is having some contrast enhancement, are going to be considered as malignant tumor. And accuracy of biopsy of the small renal mass has been evaluated by Marconi in 57 studies, and over 5,000 of cases has been reported, and the rate of diagnostic of small renal mass is about 92%. So precision biopsy technique will reach to over 90% accuracy. Another study also recommended that the sensitivity is almost 97% and specificity is 96%, and positive predictive value over 99%, with a poor negative result in 68%. And non-diagnostic rate, or if it is not been diagnosed, the second attempt of the biopsy is going to be more accurate. That non-diagnostic case may vary from 0 to 22% or 20%. But if we do correctly, then the surgical pathology may be revealed in almost 90% of the cases. So repeat renal biopsy is very important way to help. And imaging about the small renal mass has been discussed widely, but I would have to emphasize that the MP-MRI of the renal mass may give us some clue that it can differentiate between the oncocytoma and the RCC, or it can also give some idea about the angiomyolipoma. Contrast ultrasound is not available in our country, also in India, but I think there is some potential to help you. And I believe that the biopsy is more important because the new histological and molecular markers can be identified. Using the PCR technique, fluorescent and hybridization, the FISH technique or microRNA analysis will give us perfect understanding about the tumor. So which tumor can be under surveillance and with active surveillance, and which tumor should be operated, we'll be able to know it before we intervene. There are some important factors why this biopsy is deferred by the urologist. There is a strong belief in the urologist community that the small renal mass biopsy will not eventually change the management protocol, which is not correct. False positive rate up to 5% and false negative rate may be about 25%. So that also comes in mind of the treating physician or the urologist. Another important factor is that the biopsies are being taken by the radiologist who are not specifically oriented with the renal biopsy. And surgeons are also not very much familiar with this. And uroradiologists are not available in this part of the world. So those are the inhibiting factors which do not help to popularize the biopsy in small renal mass. But over the time, I believe that this should be overcome, and the biopsy of most of the suspicious renal mass, small renal mass, should be done in every center. Having said that, I will to stop here. Thank you
so much, sir. Sir highlighted a very important point with the advancements of molecular genetics. It might be possible that we are going back and starting to biopsy more and more SRMs as well to understand and formulate the treatment. Thank you so much, sir. So this patient who had a FNA and was non-diagnostic, I then saw her at that point of time. We waited for 14 days and did a contrast CT because we thought FNA will have some impact with the blood there. and that was the finding. The patient did not want any more observation and opted for a robotic approach. I did a robotic partial nephrectomy. But I want to ask a question. In this forum, we had robotic approach, we had LAP. Ginil spoke about LAP as well. And Sanjay did talk about the open approach. So I'm going to request Dr. Tongaonkar to tell us, is there a choice of preference or is it open for all? Depends upon the individual surgeon's preference. Let's hear from sir now.
Thank you, Dr. Raghavan. Am I audible?
Yes, sir.
Yeah. So whenever you approach a patient for a partial nephrectomy, the traditional gold standard has been an open partial nephrectomy. And the traditional indications have been T1A and select patients of T1B. Now, which is the best? I think rather than thinking about which is the best, we should think about which is the best for a particular patient. There are no RCTs of head-to-head comparison, and what we have is mainly a retrospective data, a cohort studies, and a very few prospective studies which are comparative but with a short follow-up. So when we compare, there are certain parameters that one looks at. The previous one, please. Previous one.
Yes, sir.
Yeah. And if you look at the peri-operative outcomes, complications, renal functional outcomes, surgical margins, and DFS-OS. But actually, if you go to see, in terms of importance, it is the oncological outcomes which are more important, and the peri-operative outcomes, although important, are not so important. If you ask the patient whether you take 20 minutes more for surgery or you take 2 days more of hospital stay, the patient will say, I'm not bothered. You give me a good oncological outcome. Next, please. And when we compare laparoscopic and open partial nephrectomy, I just quote one study, which is a multi-institutional study from 3 high-volume centers of 1,800 laparoscopic and open partial nephrectomies. And if you look at this slide, in the open partial nephrectomy arm, there were more patients who had symptomatic presentation. The tumor size was larger, more central tumors. There were more tumors in solitary kidney. And yet, in spite of that, the complication rate was much higher in the laparoscopic arm. And I'm not talking about somebody who's learning. These are high-volume centers. They are very reputed laparoscopic and open surgeons. So I think laparoscopic surgery, although it had certain advantages of early recovery, etc., it did not really add much. It did not much advantage over open partial nephrectomy. Next, please. Next. Coming to laparoscopic versus robotic, I mean, there have been many studies and there have been 5 meta-analyses, as you see. I'm just going to quote 2. The one by Leo, which had nearly 5,000 patients, and here, although the robotic arm had larger masses, higher nephrometry scores than the laparoscopic partial nephrectomies, the complication rate, and especially the major complication rate, was much lesser with the robotic arm. And if you see the last meta-analysis, you can see of more than 8,000 patients, the robotic approach was superior to laparoscopic on almost all endpoints. So I think today, whenever we think of a minimal access we should think of a robotic rather than a laparoscopic partial nephrectomy, unless it's a very small exophytic mass. Next, please. What about open versus robotic? I think, again, there have been many trial reports, but must remember, none of them is a randomized comparison, and there is going to be a significant selection bias. But however, if you see the general the findings, the perioperative outcomes, operative time, warm ischemia time is definitely longer with robotic arm, but the estimated blood loss, need for transfusion, the post-op complications, and post-op renal function are probably better with the robotic arm. The oncological outcomes, which are most important, are grossly, they have the robotic partial nephrectomies have a very short follow-up. There's just 1 or 2 reports of follow-up up to 5 years, and the oncological outcomes seem to be similar. So I think robotic partial nephrectomy is definitely superior to laparoscopic and definitely equivalent, at least equivalent to an open partial nephrectomy. Next, please. Now, are there any limits to robotic partial nephrectomy or minimal access partial nephrectomy? Can it be done for larger tumors? Yes. For T1B especially, there is the record registry data which showed that trifecta could be achieved in nearly 70% patients with a robotic partial nephrectomy. Tumors with high nephrometry scores or complex renal masses, as we call them, which are anatomically and surgically difficult. Here again, the trifecta could be achieved in more than 60% of patients with a very less major complication rate of 2.3%. Remember, these are high volume centers which have reported this. The tumors in solitary kidney or bilateral kidney, again, similar outcomes, multiple tumors, similar outcomes, and patients with CKD also had similar functional outcomes. So in complex situations like this, the robotic partial nephrectomy can certainly be done, but it should be done only by expert robotic urologists at high volume centers. But open approach will still be the approach of choice for an average urologist who is, I would say, averagely trained in robotic approaches. So if the patient comes to me with any of this, I would probably opt for an open partial nephrectomy and not go for a robotic partial nephrectomy. Probably send the patient to Deepen or somebody like him who has a lot of experience. In complex situations, it is extremely important to have a proper preoperative optimal imaging and also an intraoperative ultrasound to get the optimum results. So in the last decade, there have been improvement in surgical techniques, all in open, laparoscopic as well as robotic, and which has improved the perioperative outcomes. Robotic approach is better than laparoscopic and at least equivalent to OPN. What one must remember is it is the technique which matters more and not the approach. If somebody is doing an excellent open partial nephrectomy, he should be doing an open partial nephrectomy and not just go because the robotic, there's so much literature on robotic. Whatever is best in your hands should be done. What is important is we still need to have long-term assessment of oncological equivalence between the robotic and the open approach. But one should practice the approach that one is most comfortable with which one gets the best results for the ultimate good of the patient. Thank you.
The last line probably summarizes everything. What is best for the patient should be delivered. If it is an open partial that is going to deliver the best, that should be absolutely fine as well. Don't need to be pushed to do it one way or other. But it is also equally important to note that even in the best of the hands, lap partial nephrectomy had its own complications. So perhaps in the 21st century, one should consider open/robot in their approach depending upon their comfort zone. Am I right, sir? Is that a good summary?
I was actually surprised to see one of the editorials which said RIP laparoscopic partial nephrectomy. So I don't know whether we should really say that, but yes, that is one of the things.
Thank you so much, sir. I'm going to request Dr. Yuvaraja, one of our leading robotic uro-oncologists, had been a mentor for many of us, to tell us about the intraoperative issues and tips and tricks that he will otherwise consider to handle a difficult situation intraoperatively. Sir?
Thanks, Raghavan. Can you hear me?
Yes, sir.
Okay. So I think it's a very busy slide, but still I think when we have issues during partial nephrectomy, whether it could be open laparoscopy or robotic, it is almost the same thing. So I'll just enumerate what is the cause of the bleeding and then how to tackle it. I think once we suspect arterial bleeding by bright red blood, or this is a parenchymal bleeding we are talking about, not the vascular injury. That is a separate issue altogether. So if the bleeding is there in a pulsatile manner, first you just check the BP, it will be very high, then ask the anesthetist to correct it. And then if the vein is clamped, this is the most common, which I have seen in my hands, that if you keep the vein clamped and you miss one artery, so then you will have a lot of bleeding. So in that, immediately when there is a bleeding, arterial bleeding, immediately unclamp the vein. So that will prevent further bleeding. And the third one is that inadequate pressure from the current clamp. Sometimes due to atherosclerosis, if you put only one clip, it may not able to occlude the entire artery. So that is the reason, as Deepen told, even I put two clamps onto the artery. If you have not done it, you put one more clamp, and very rarely Satinski will be required. It's very difficult to introduce. It takes a lot of time. So anyhow, so one more, even a bulldog clamp is sufficient. If you have a missed an accessory artery, possible, so then you would have to try to, but it is very difficult when there is a bleeding. So we generally, these accessory arteries are very small. Even during bleeding, you can continue. So that's what the next point is, that persistent but manageable bleeding, you continue suturing as early as possible, take out the tumor and suture it back. And with these all measures, so the last option will be converted into open. Very rarely it is required. So as of now, I've done 260 cases of partial robotically. We are not convert because of the bleeding into a open surgery or a nephrectomy. We have done it only for the tumor problems. So, and the next is the final, we know that it is a nephrectomy. So that is how we tackle arterial bleeding. Venous bleeding, so again, it is the similar one. If you think that, it is bleeding a little bit, it is hindering your surgery, increase the pneumoperitoneum. If the vein is not clamped, but you see a dark blood color blood coming out, then you clamp the vein. And especially in hilar tumors where we expect venous bleeding. And on left side, this is the commonest mistake when you do venous clamping. If you do it medial to the veins like adrenal and gonadal vein, black bleeding will be more. So that is, you have to clamp lateral to the vein. And persistent but manageable bleeding, so you have to do it very faster. Unmanageable bleeding, venous bleeding is extremely rare, but you have an option of converting it to open or nephrectomy. Next slide. So even after that, sometimes we do rhinorrhaphy and open the clamp and there is a still parenchymal bleeding. What to do? So tighten the clips. This is the most important thing. Sometimes the whatever we have taken the suture is not tight, tighten it. Extra suture, you can add it or use sealants. I think this is all, 99% of the situation. Very rarely you have to do nephrectomy. And you can use fibrin sealant, whatever it's available, gel foam, flow seal, Hemosil, whatever. So I think this is for only the smaller bleeding. Next slide. So when you open a pelvic calyceal system, what to do? So minor calyx, even a major calyx, so you have to just take a inner rhinorrhaphy, then it will include both the vessels as well as pelvic calyceal system. You can see it and suture it. Very rarely you require to put a stent, especially in medial tumors where you open a major part of the pelvis. So otherwise there is no need to do that. And you keep it drained a little longer and keep abdominal drain. That's all. So next slide. So the most important is that, as Deepan told and Dr. Emil also told, that ease of instruments, especially in SI, though there will be a lot of clashing outside the body. So you have to be very, very careful when you put the instruments. And in XI, luckily we don't have that issue. So that's the reason I stopped doing kidney surgeries on SI. So I do only on XI. And the most important is the instrument selection. So I would prefer not to take Maryland, because Maryland is a very sharp instrument. When we dissect around the renal artery and renal vessels or renal vein, it will be a little difficult, especially for the beginners. And suturing needle, we know that where to catch the needle and all those things, we are aware of that. And important is that kidney will be floppy, especially in posterior tumor. So that is the reason. So keep the one pad of fat in anterior tumor, lower and upper polar tumor, but we don't have any option in posterior tumor. So we have to do that. Next slide. So now these are the suturing angles. You can see that. You can play the video, Raghavan, if you can do that.
Yeah.
Oh, okay. You increase it. It's fine. No problem. So you play it. So, so this is the tumor where we, posterior lateral tumor, what I usually do it is that we take inner rhinorrhaphy by 2 layers. So this is what I use, Statafix 30. You can do 2 sutures. Generally 2 sutures sufficient 90% of the times. So very large defects, sometimes I took 3 of them. So it's so you can include both the pelvic calyceal system as well as this thing. So that's what we do, the inner rhinorrhaphy. It controls almost all the bleeding. And the outer rhinorrhaphy, I do it in a different way. So I put I take 2-0 Statafix. So very subtle barbs it has. And then we put clip on both the sides, unlike Deepan puts on one side. So because I am really worried about parenchymal tear when you tighten it. So you can do it very easily when we do it robotically. So that's how we do it. So I think most of the times bleeding can be managed. Oh, that's enough. That's enough. You can stop the slide. So most of the times we can easily manage these complications, not to worry about it. Thank you so much.
Thank you so much, sir. There are a lot of discussion in laparoscopic era. People used to do a single layer closure. In robotic era, when we started doing large tumors, we say even you can leave it open, just do the inner layer and go out, and if you leave the rest of the things open. And there is another question about, especially the patient which I showed, where that's a very posterior tumor, you need to do a full flip. Should we do a nephropexy at the end of the day? So I have 2 questions to ask you. What is your take on rhinorrhaphy? Should we do it or not do it, or can we leave it open? And if you have to mobilize, do you prefer to do a nephropexy or not?
No,
I want to take your opinion and Dr. Heyman's opinion.
Okay. My honest opinion is that whenever I do renal parenchymal, I do exactly what we do it in open surgery. So there is no need to compromise there. And we have to sleep well and patient has to be well. So this 2-layer renography I learned from Dr. Tongaonkar. So same thing I'm doing, inner renography and outer renography. I have not tried anything except in a very, very superficial tumor when you can get away with 1 layer. Why they practice in laparoscopy 1 layer? Because there was a lot of time to take suturing. So to avoid ischemia time, they did it. But when you can do it, finish in 15, 16 minutes, I don't think we should be thinking of any, I think safety is more important. Anytime, even a small blood vessel sits, so I don't agree with that. And the next is nephropexy. When you completely mobilize the kidney, the entire fat and the patient is very lean, I would prefer to keep the kidney back in the same position. I have not heard of any vascular compromise when the kidney is flopping and coming down. I have not heard of it. But even then, the most important what I feel is that even Dr. Tongaonkar is to tell me that put the fat on that so that at least next time when you come, we are not sure that patient may develop any pathology in the kidney. When you come, you have a good fat around that, and it is in the same position where we need not search here and there. And even it may develop some stone diseases, and they may have to do a percutaneous procedure for those things. I think we should keep as far as possible in the same position and wrap the remaining kidney with the fat which is available. I think that is what I feel.
Superb, sir. And Tongaonkar, sir, do you have any other opinion, sir?
Yes, what I do normally is if it's a very superficial tumor, then I can just leave it open like that and just maybe fill with fat and just. But otherwise, if it's depending on the depth of my resection, I would do a 2-layer or a 3-layer, renography, and that is the standard of care. I think I don't compromise at all. If you just take one shortcut, you are definitely going to land up in some problem, sooner or later. Nephropexy, I don't mobilize the whole kidney unless it's for a very large tumor. So most patients don't really require a nephropexy. Okay. If you have mobilized the whole kidney, somehow, and I do an extraperitoneal when I do an open. So there's no question of, too much of space for the vascular compromise or anything like that. So that takes care of itself.
Thank you so much, sir. Raghu and Srivaj, I have a question. If imagine the same patient had a single enlarged node in the hilum, suspicious, and nowadays, as you said, everybody gets a PET. Even for a cough and sneeze, we do PET, and that PET shows some enhancement. Raghu and Srivaj, the question is, would you just do a nephrectomy for that patient? Would you still do a partial and do a lymphadenectomy? What will be your take? Raghunath? Srivaj, are you there?
Yeah, I am here, sir. I think Dr. Raghunath, sir, can you unmute yourself?
Okay. See, why don't you answer the question while Raghu is trying to unmute and get going?
Yeah, sir, I think the choice of whether to do a partial nephrectomy or radical nephrectomy will depend on the overall renal function of the patient.
Okay.
So, and if there is an enlarged node.
Let a 24-year-old, fully functioning kidney, GFR is fine, creatinine is 0.8, absolutely same patient. There is a single node which has some dubious enhancement on PET as well. My question that I'm trying to tease out is that, is it a sin to do a partial nephrectomy when there is a suspicion of an enlarged node? That's the question.
Yeah, if the node is suspicious, I would probably go in and probably remove the enlarged node and send it for frozen section before I decide what I would do with the kidney.
Let us say that enlarged node comes as a positive disease. What will you do?
Since it's a very young patient, fully functional system on the other side, I think the current recommendation is to do a radical nephrectomy and probably do a formal RPLND.
Okay, thank you so much. And Raghu, has he unmuted and is he ready to answer? Okay, can we put the same question to Yuvaraja sir and Tongaonkar sir? Same question?
Yeah, I think Raghavan, what Srivasa told is perfect. So if there is an enlarged node, that means lymphatic channels are there. There is a permeation of these cancer cells to the lymph node. Okay. I think we should not take any risk in that because oncologically it is much more important than the kidney. I think I would remove the kidney. So almost my around 20-30% of my partials, I send some node because when you're dissecting hilar, some nodes will be visible which are enlarged, so I send them for frozen. Yes. So in only one occasion, I have to do the nephrectomy because lymph nodes were positive. So okay. I think that's the way to go.
So the take-home message is that if there is a involved node, it will be better to choose a total radical nephrectomy and not compromise the oncology. Tongankar sir, will you agree with that point as well?
Yes, but I'm not perfectly. I'm very sure whether we need to do a radical nephrectomy if the node is positive, because it's the distant. It's basically a systemic spread. Whether you do a partial or a radical, there is not really going to matter much, unless the node is making your, compromising your partial nephrectomy procedure. So I think if the tumor is far away and there's a hilar node, I can even still do a partial nephrectomy and
then complete RPLND there as well.
Yes.
Okay. But we have two views on that matter. It is a very interesting point. So I just want to touch upon one another question now. SBRT is making a lot of headlines all over the place, and I'm going to invite Dr. Rahul to tell us about the role of SBRT in a patient who's not willing to undergo a surgery for a small renal mass. The
Good
slides
evening,
are busy,
everyone.
so if you summarize it, it will be very appropriate.
Yeah. So
thank you, sir.
Good evening, everyone, and thank you for giving some space for SBRT. Yeah. So no, RCC is surgical disease for sure, and we do not have any randomized or level 1 evidence to be competitive in that effort. But yeah, it can be complementary for patients who are frail, old, and not suitable for surgery, or patient very much adamant on not having a surgery may be offered. But experience is very limited to certain centers, and mostly it is retrospective in patients of certain type which are selected, which I just mentioned. So this is IROC, which is the International Radiosurgery Consortium for Kidney. And what you see here is the experiences of almost 200 to 23 patients. And what essentially you see is KPS of more than 70, and the histology is primarily clear cell as, the demographic of it, but doesn't give you substantially which one not to choose. But mainly those are the patients which are outchosen of the surgical approach. That's why they are taken up. So if you go to, if you see the, sorry, just go back, sorry. Yeah. So if you see the local control rates, they are pretty good. So which, stand test of what earlier was thought it's radio resistant, and probably things are changing, right? So because of the technology that we can give much higher dose and equivalent dose, so local control rate is almost 100%, with the median follow-up around 4 to 4.5 years. So next slide. So what you see in the the Kaplan-Meier and the multivariate analysis, the ECOG status is the most critical one, which defines their survival, and then the maximum dimension. So as the size of the tumor increases, the success of radiation dose decreases. So you have to go higher on the dose, but that becomes the more challenging because more number of organs at risk, such as duodenum or bowel, will be entangling that mass. So that becomes a difficulty. But apart like coming to the converse side of surgery, so the endophytic tumors or the tumors in proximity to the vessels and collecting vessels is not a limitation for SBRT, or even for thermal ablation. Failures can be easily taken up for SBRT. So next slide. This is just an anecdotal thing, which is in the same part of analysis. So GFR, which becomes critical in such frail and old patients, many a times the surgery will be difficult, or the anesthesia will be difficult because of that reason also. So what you see here is that around 25% of the patients might have an improvement in the GFR or the creatinine values post radiotherapy, so which might be due to decompression, or what we poorly understand why it happens, but you can expect sometimes an improvement. Still, a cutoff of 30 ml per hour is taken for radiation selection of patients. Next slide. So this is what the size relation, because the whole seminar is basically for the small masses. So if you go increasing the size of the tumor, you see that the efficacy of the radiation dose, if it is constant, it goes down. So you have to go dose escalation as the tumor size increases to 5 centimeters or more. And this is from the SEER data, basically. The next slide. So if overall I have to summarize what patients are suitable. So basically the patients who deny or nephrectomy or surgical choice is no longer a choice. So basically we can compete practically with cryoablation or radio RFA when you really think that patient needs a treatment to have a better survival. Those are the primary lesions that we would like to address upon with radiosurgery. And also in metastatic settings, when we do a lot of, if there are only 2 or 3 mets, we are doing oligometastatic radiotherapy. then we can do for the RCC also in similar setting.
Thank you so much, sir. The SBRT is making its way into lots of things which otherwise was untouched before. So it will be an interesting space to see where we are in the future. I'm going to request Dr. S.K. Singh to tell us. There was a lot of point Dr. Yuvaraja kept telling that convert into nephrectomy if you are not able to get your vascular control during a surgery. So nephrectomy is never a bad choice for any patient. It has been the standard of care for many, many years before partial set on. But in the era when the partial nephrectomy is available, are there any particular way you choose a patient for doing a radical nephrectomy? So I'm going to request Professor S.K. Singh to talk about this now.
Thank you, Dr. Raghavan. I think I am talking something odd for the situation where we are thinking of partial nephrectomy in SRM and very conservative measure just to salvage the kidney. But yes, the situation can be odd when the partial nephrectomy is not possible, or partial nephrectomy is not feasible, or partial nephrectomy is not worth doing. So now this situation could arise. This situation could arise due to tumor-related factor, due to patient-related factor, and even surgeon-related factor. During surgery, something happens, or maybe the surgeon is not confident of doing. Certainly, he should refer the case to some expert for partial nephrectomy. He can't deal with the highlight tumor. But same time, yes, during surgery, certainly some is happening can again decide the surgeon to save the life of the patient, because the salvage of the patient gets priority over salvage of the kidney. Now, when the kidney is not functioning, I think doing partial nephrectomy is not worth doing. Or there may be a special situation when it could be again the radical nephrectomy will have death result for deciding for that. So can have next case. So now now we see the situation. The patient on the right side has got small tumor in the hilum, and has got renal vein thrombus and as well as IVC thrombus. Now here, the life salvage of the patient again gets priority over salvage of the kidney. So certainly one will think of doing a radical nephrectomy, will plan for radical nephrectomy and thrombus removal rather than again venturing for partial nephrectomy. See the other side, left side kidney, again the vessels all around, again major vessels also it's difficult again to discern which is how to isolate and how to do partial nephrectomy. I think it cannot be done. I will say, yes, even in best hand, person will think of doing radical nephrectomy. Now the prerequisite for radical nephrectomy remains contralateral kidney should be normal functioning, should be functioning normal, and patient should be fit for surgery. That is the prerequisite before deciding for a radical nephrectomy in the small renal masses. Yes, I think one may think of going for bench surgery, yes, but again, in patient who is quite elderly like this, tumor like this, I have just now seen Dr. Hemel has shown by transparenchymal approach to this kidney, this tumor, and again, nucleation could be tried and the partial nephrectomy is possible. But I think in elderly patient, when the patient has a lot of morbidity, the radical nephrectomy should be the choice in such situation. Yes, again, here the kidney is not functioning. Now, this is the situation when the patient has end-renal stage disease and patient has acquired renal cystic disease and tumor is associated. I think nobody will think of partial nephrectomy in this situation because it's not worth doing it. Yes, and the last situation is there can be a special situation. Somebody has done biopsy due to something, and then it is sarcomatoid RCC or medullary RCC, or it may be a case of HL RCC, heredity, again, leiomyomatosis RCC, and there is hereditary succinate deficiency. In these cases, risk to the patient life is more, again, so therefore, one will yield towards doing a radical nephrectomy rather than partial nephrectomy. Thank you very much. Yes.
Thank you so much, sir. You cannot summarize it better. Kidney, patient-related, tumor-related, surgeon-related, and unusual circumstances. Excellently put, sir. Thank you so much. So the partial nephrectomy was done. It was straightforward, macroscopically clear. It was diagnosed as a chromophobe RCC, low grade, equivalent to Furman grade 1. One area, focal area, where the tumor was reaching the ink margin. I purposefully twisted the last point just because I want to understand how we are going to follow these patients. So I'm going to request Dr. P.B. Singh to tell us a bit more about the follow-up of these patients. Please, sir.
Can you hear me?
Yes, sir.
Can you hear me?
Yes, sir, we can hear you, sir.
Okay, okay. Thank you very much. I will just give an example of a case and how I have followed, and I think that will explain. And this is a patient with a solitary kidney with a big mass, and he consulted many hospitals, and ultimately they told radical nephrectomy, but he came to us. We thought we'll do it. We did the CT angio as well as 3D reconstructions, and then we did the embolization of feeding vessels, and ultimately we did the partial enucleation of the tumor. You can see the slide here. Sorry.
The one before, sir? You want this slide?
Yeah, yeah.
Yes, sir.
So you can see here, already we have done a partial nephrectomy. Then comes the follow-up. In this patient, the first follow-up was done at 3 months. This patient already had a PET scan, and I told him the PET scan is not required in follow-up, but because the patient was having a PET scan, he requested, sir, do a PET scan, then get me more confusion. And if you see the report, in this report, FDG avid ill-defined thickening as superior margin, but this FDG activity of the thickening is much greater than primary renal mass, and probably this is because of inflammatory. So this is the problem with the PET scan. So we never recommend a PET scan. Usually PET scan is not recommended. It is follow-up is at the 3 months with the CT or MRI with the X-ray chest, and subsequent follow-up has to be done every 6 months for 3 years with CT KUB and CT chest, and then yearly at least for the 5 years once we are doing a nephron sparing surgery. And in this patient is over 1 year now, the normal creatinine and the CT is normal. So this is how the follow-up is required, because once we are doing a nephron sparing surgery, we have to be very, very cautious. Patient may have a recurrence. So our follow-up is very, very important, at least for 5 years. So this is what a protocol we follow in the follow-up. Thank you very much.
Thank you so very much, sir. I'm going to summarize now. So SRM is being diagnosed in an increasing fashion thanks to mass trail checkup and increasing use of the radiology. A CT urogram is mandatory, or appropriately done imaging is mandatory. Biopsy is not mandatory, but as Professor Salam said, it may become an important factor with the molecular genetics coming in future. FNAC is usually not useful. Approach is purely based on patient and surgeon's comfort and convenience. Appropriate instrumentation and skill set is mandatory before dealing the complex tumor. Renography, as all the seniors have put it, will be very useful and should be done. Nephropexy, if you mobilize the kidney in full. Presence of an enlarged lymph node may not warrant RN, but if that is going to be an important factor, do not hesitate to do a nephrectomy, and follow-up is absolutely mandatory. I thank all the seniors who have participated in this. Thanks the audience and the organizers, Kulkarni sir, Raval sir, Ganesh and Sanjay. Thank you so very much.
Thank you, Dr. Raghavan. It was indeed a very nice panel. And I also have to say thank you to Ferring, who provided educational support and digital support to this meeting. I thank again
the audience, Ganesh, sorry. Audience count?
Audience count was 286 plus the ones who are here.
Okay, thank you.
286. Thank you, everybody. Sanjay, maybe you can speak.
It was, you always think that you know, and then you listen to people who know a lot more than you do, and then you think you know very less. Thank you very much, all my teachers and mentors, friends. It was extremely good.
Thank you.
Okay.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Thank you, sir.
Stay safe.
Yes, sir.